trauma que ocorreu na semana passada em Campinas, da Unicamp, e também pelo apoio que tivemos com a nossa fundação, a FUNRIO, da Universidade Federal do Estado do Rio de Janeiro. Neste simpósio, nós vamos ter a presença de renomados cirurgiões de trauma do mundo inteiro, representantes da América, da Ásia, da Europa e da África, editores das melhores revistas de trauma do mundo e profissionais de excelência e qualidade no trauma. Acredito que teremos a casa cheia e agradeço novamente a presença de todos os convidados estrangeiros que estão aqui na Academia Nacional de Medicina hoje.
Boa tarde. Excelentíssima presidente da Academia Nacional de Medicina, doutora ELIETE BOUSKELA, gostaria de agradecer esse honroso convite e a oportunidade de discutirmos nessa casa um tema tão relevante para o nosso país. Ao acadêmico José Camargo e ao acadêmico Rossano Fiorelli, o agradecimento de todos os colegas do Brasil e do exterior que vão poder fazer as suas apresentações ao longo dessa tarde de hoje, a fim de compartilhar experiências, não só com os acadêmicos da Academia Nacional de Medicina, mas também para o público que está aqui presente e que nos acompanha online. Será uma tarde e noite de grande aprendizado, né, num cenário de educação médica no nosso país extremamente complexo, um grande número de faculdades de medicina. Tive a oportunidade de, em março, estar nessa casa acompanhando uma sessão sobre ensino médico e eu acho que nós temos que qualificar também os residentes através da criação de programas de residência médica e a discussão sobre especialidades que são necessárias no nosso país para o tratamento da nossa população. Obrigado por essa oportunidade e, com certeza, aprenderemos muito no dia de hoje. Obrigado.
Bom, então, dando início, eu gostaria de convidar o invite o professor Arda Isik, da Turquia, que fará a primeira palestra, que será sobre epidemiologia e causas externas de morte no mundo e nas guerras.
Dear President, dear colleagues, good afternoon. Today I will speak about epidemiology of external causes of death in the world and the wars. At the beginning of my speech, thanks for kind invitation, President of National Academy of Medicine, Professor ELIETE BOUSKELA. And last week we were in Campinas. There was an amazing congress, World Congress of Emergency Trauma League. Thanks for this amazing event to Professor Gustavo Fraga. So I came from Istanbul. Istanbul, Turkey is famously known as the city that spans two continents, Europe and Asia. I work at the University Hospital located in Asian side. We have almost 1,000 beds. As an agenda, definitions, rates, trends, regions, and conclusion. External causes of death refer to death due to causes not related to disease, but to environmental or behavioral events, including road traffic accidents, drowning falls, fire and burns, poisoning, violence, wars, and earthquakes. External causes account for 8 to 10% of all global deaths annually, 4.4 million deaths worldwide in 2023 due to injury-related causes. Leading external causes globally: road traffic injuries, suicide, homicide, war, conflict, and earthquakes. We had a severe, very devastating earthquake in 2023 in south part of Turkey. Some instance immediately after the earthquake. A very large region was devastated by the most devastating earthquakes of this century. A large area in Turkey and Syria was affected by these earthquakes. Thousands of people lost their lives, while hundreds of thousands were injured. Due to the devastating effects of the earthquake, millions of people had to migrate from their living areas. Here we see the before and after pictures of the earthquake.
Mustafa, haydi selam söyle, iyi misin? Canım benim, haydi.
Almost 50,000 people dead and more than 100,000 people injured. So, what are unintentional injuries? Road traffic injuries are the first cause of death among people aged 5 to 29 years old. According to the WHO, over 90% of global road traffic accidents occur in low-middle income countries, even though they have only about 60% of the world's vehicles. Why is the road traffic accidents so high in low-middle income countries? The causes are poor road infrastructure, weak traffic law enforcement, unsafe vehicles, alcohol, substance abuse, lack of driver education, licensing control, rapid urbanization, and motorization. And intentional injuries are suicide. This is the 9th leading cause of death globally, highest rates in Eastern Europe, parts of Asia. Disproportionately affects men and young people. And we also see homicide, highest rates, Central and South America, Sub-Saharan Africa. Latin America and Caribbean, which have just 88% of the global population, account for around 1/3 of all global homicides. While high-income countries report higher suicide rates, low-middle-income countries may have higher actual numbers of suicides, but underreporting and stigma obscure the data. War-related deaths are episodic but have surged in the last decade due to Syrian civil war, Yemen conflict, Ukraine-Russia war, Sudan and Ethiopia conflicts, and Gaza-Israel escalation. As seen at the table, it increased by the years. When we look at the war mortality by region, Middle East and North Africa as MENA region, more than 1 million deaths since 2000. In Sub-Saharan Africa, hundreds of thousands. And Eastern Europe, Ukraine conflict caused more than 150,000 deaths. Decline in war deaths in the early 2000s, followed by a resurgence post-2010. Shift from interstate wars to civil wars, hybrid wars, and proxy conflicts. Terrorism-related deaths surged after 2001, peaked around 2014, and then declined. So what are global health and policy implications? Violence prevention, trauma systems, injury surveillance are essential. Conflict resolution, disarmament, and protection of civilians are key humanitarian priorities. Long-term effects include mental health crises, displacement, and collapse of healthcare systems in conflict zone. The increasing frequency and severity of global emergencies necessitate a coordinated international response to effectively manage and mitigate the impact on affected populations. Our collaboration aims to combine our expertise, resources, and innovative approach to enhance the efficiency of emergency surgical interventions. By pooling our collective knowledge and capabilities, we can improve patient outcomes, streamline operations, and develop best practices that can be adapted globally. Deaths from war include combatant deaths, civilian deaths, indirect deaths from famine, disease, infrastructure collapse caused by conflict. As senior indirect civilian deaths, about 1.5 times the scale of direct civilian deaths during wars. When we look at the regional highlights, Syria, more than 500,000 deaths, Iraq, almost 270,000, Yemen, 377,000, Gaza and Israel, tens of thousands, Libya, around 30,000. And Sudan, Darfur, 400,000, Ethiopia, 600,000, Congo, millions over decades, Somalia, Mali, Burkina Faso, significant ongoing violence. And when we look at Eastern Europe, Ukraine and Russia war, 2014 to 2021, almost 14,000, and 2020 to 2024, full invasion, more than 150,000 deaths. In Asia, and in Asia, Afghanistan, more than 170,000 deaths. In Myanmar, escalating since 2021. In Pakistan, significant terror deaths. This heat map from our world in data shows where conflict-related deaths occurred, with the highest intensity in Sub-Saharan Africa, the Middle East, and parts of Eastern Europe. This map highlights not just total numbers, but rates of deaths relative to population. Again, hotspots include the Global South, especially African and Middle Eastern countries. A recent map emphasizes extremely high death rates in specific conflict zones like Eastern Africa and Ukraine. This map outlines where active wars and heavy violence hotspots are today. Useful to see the geographic speed of current conflicts. War-related deaths are fewer in total, but cause massive surge in specific regions, destabilizing whole health systems and societies. And when we look at the trends, modern wars kill fewer people directly than 20th century conflicts, but have massive indirect and long-term impacts. Civilians now represent the majority of war deaths. Technological warfare increasingly affects non-combatants. When we look at the public health impact, collapsed healthcare such as in Syria, Gaza, epidemics such as in cholera in Yemen, mental trauma, post-traumatic stress disorders, migration, over 110 million forcibly displaced people worldwide. I would like to categorize the public health impact here as forced displacement, such as in Syria, Ukraine, Gaza, healthcare collapse in Syria and Gaza, epidemics. epidemics in Yemen, mental trauma, psychological distress and orphanage children, humanitarian impact in refugee camps. Here is airstrike that is almost 1 month ago seen between Iran and Israel from a college of mine. We see here the airstrikes of Iran to Israel and Israel to Iran. Every hospital is just one incident away from being overwhelmed. Preparedness saves lives. Collaboration across disciplines is essential. Here you see the numbers, not the names of the dead. There are over 50,000 dead and over 100,000 injured in the devastating earthquake in 2023 in south part of Turkey. As I conclude, external causes of death account for 8 to 10% of global mortality. The burden is highest in low and middle income countries. Wars and conflicts have devastating public health consequences with indirect deaths often exceeding direct combat fatalities. Prevention, trauma systems, mental health services, and humanitarian responses are essential. A comprehensive global approach combining policy, health system strengthening, and conflict resolution is vital to save lives and protect societies. So in October 21st to 25th in Antalya, in south part of Turkey, we will have a amazing congress, WSES, World Society of Emergency Surgery Congress. I invite the president and all colleagues to this congress. Thank you very much.
Thank you, Dr. Arda. For the next presentation, I'd like to invite Dr. Rodrigo Caselli Belém. He's from Hospital de Base, Distrito Federal, Brasília. He will talk about the epidemiology of trauma in Brazil.
Boa tarde a todos. Gostaria inicialmente de agradecer a presidente da Academia Nacional de Medicina, doutora ELIETE BOUSKELA, pelo convite. Muito obrigado. Em nome da qual cumprimento todos da mesa, todos os palestrantes e todos os convidados a essa sessão. Me cabe falar um pouquinho sobre a epidemiologia do trauma no Brasil. Eu me chamo Rodrigo Caselli, eu sou cirurgião de trauma do Hospital de Base do Distrito Federal. É um centro de trauma, é um hospital que trabalha com equipes e estruturas dedicadas exclusivamente ao atendimento ao paciente traumatizado. E nós vamos falar um pouquinho sobre essa triste realidade que assola o mundo e assola o nosso país também. Como já foi mostrado aqui, o professor Edan mostrou, os números do Brasil, eles impressionam. Quando a gente compara o que ocorre de mortes em guerras pelo mundo todo, nós vemos que o que morre no Brasil, atualmente, de pessoas, é mais do que morreu em 20 anos de guerra no Afeganistão. Atualmente, e foi assim pelos últimos 10 anos, os últimos dados do Ministério da Saúde compilados são de 2023, nos últimos 10 anos, nós mantivemos a média de 150 mil pessoas mortas anualmente vítimas de trauma. Isso significa 400 pessoas morrendo diariamente por causas externas, como se fossem 4 aviões caindo todos os dias no Brasil e as pessoas morrendo disso. Quando a gente fala na população geral, a gente sabe que o trauma ele ocupa a 3ª causa de mortalidade geral. Fica atrás das doenças cardiovasculares e das neoplasias. Entretanto, quando nós pegamos a nossa população de 1 aos 49 anos, a nossa população economicamente ativa, essa diferença fica gritante. O trauma é disparadamente a primeira causa de morte, sendo que as outras duas somadas juntas não chegam nem à metade do número de mortes que nós temos por trauma no Brasil. Isso nos últimos 10 anos, e continua sendo assim. Quando nós pegamos essas causas externas e dividimos por subgrupos, infelizmente o cenário não fica muito melhor. A gente sabe que a violência é a principal causa de morte por causas externas no nosso país. Claro que existem algumas diferenças regionais, algumas diferenças locais, alguns mais, outros menos, mas, via de regra, a violência é a primeira causa de morte nessa nossa população jovem. Seguida depois dos acidentes de trânsito e das quedas, principalmente das outras causas que são consideradas aqui no Brasil, especialmente as quedas de própria altura e as quedas de planos elevados, de outras alturas. Mas, ainda assim, a gente consegue perceber que, dentro dessas causas, a violência, ela ocupa um lugar de destaque bem separado das outras causas. Infelizmente, a nossa estatística continua desse jeito nos últimos 10 anos e nos últimos 5 anos, especificamente, com relação a esses dados. Quando a gente começa a especificar mais esses dados, os nossos dados eles não são muito homogêneos. Os dados de mortalidade eles vêm basicamente do Ministério da Saúde, que são uma fonte mais homogênea. Então, os dados específicos dos tipos de trauma eles variam muito conforme o local, conforme a região. Mas eu acredito que não variam muito com relação a essa média. Então, o que nós pegamos são dados próprios do nosso hospital, que mostram que, dentro do centro de trauma, as principais causas de internação dessas vítimas por trauma, os acidentes de trânsito, a violência e as quedas, elas são as principais causas de internação. Então, os acidentes de motocicleta, os atropelamentos, bem como a violência, são não só as principais causas de morte, mas as principais causas de internação desse grupo de pacientes. E quando a gente fala em lesões, as principais lesões que acometem essas vítimas por região anatômica, nós vemos que os traumatismos cranianos, eles correspondem, isolado ou associado a outras lesões, a quase 60% dessas lesões. Está aí a importância do evento recentemente realizado aqui no Brasil, com o professor Andrés Rubiano, sobre o consenso para o tratamento dos pacientes com traumatismo crânioencefálico. É um grande problema de saúde pública que nós temos, está relacionado a boa parte da mortalidade dessas vítimas, como eu disse, isolado ou associado a outras lesões graves. Os traumas de tórax, presente em 25%, praticamente 25% desses casos de internação, e que estão relacionados também a boa parte das causas de mortalidade dessas vítimas, e os traumas abdominais ali com entre 18% e 20% desses casos de internação por trauma. E a gente precisa lembrar que, quando a gente fala em vítima fatal, precisamos lembrar que, para cada vítima fatal, estima-se que nós temos de 3 a 4 vezes esse número em sequelados, seja definitivos ou temporários. Então, são números bastante expressivos, são números bastante ruins de se mostrar e permanecem dessa forma pelos últimos 10 anos. E nós estamos falando só no impacto pessoal, no impacto psicológico, e nós temos que lembrar também dos impactos econômicos disso aí, do quanto se gasta com essas vítimas de trauma, tanto do ponto de vista dos custos diretos quanto dos custos indiretos. Aquilo que se deixa de produzir, como nós falamos, é a principal faixa da nossa sociedade, a faixa mais economicamente ativa de nossa sociedade, né? E estima-se que esses dados aí vão para mais da cifra de bilhões, de 300 bilhões anuais de dólares gastos na América Latina com relação ao atendimento às vítimas de trauma. Tá? Então, são dados muito importantes. E o que a gente precisa pensar é o que exatamente nós fizemos nos últimos 10 anos para mudar isso daí. Nós vimos que os nossos dados continuam os mesmos, continuam morrendo 150 mil pessoas por ano. E o que nós fizemos? O que nós fizemos do ponto de vista de governo, do ponto de vista de órgãos reguladores, Ministério da Saúde, Conselhos Federal de Medicina, Conselhos Regionais de Medicina, o que nós fizemos do ponto de vista de sociedades civis organizadas, Colégio Brasileiro de Cirurgiões, Sociedade Brasileira de Atendimento ao Trauma, o que foi feito nesses 10 anos de efetivo? O que nós, como profissionais, como médicos, como enfermeiros, o que nós fizemos para mudar essa realidade? Muito esforço foi despendido, provavelmente fizemos muitas coisas, mas os resultados estão aqui. Os dados mostram que o que fizemos até agora não foi efetivo para poder mudar essa realidade. E eu gosto de deixar esse vídeo aqui, porque nós estamos falando muito em números, né? Mas, na verdade, não se trata de números. Esse é um vídeo da Austrália, do governo australiano, do estado de Vitória, que fala um pouquinho sobre isso daí. É um vídeo bem rapidinho.
So last year, 249 people died on our roads. What do you think would be a more acceptable number?
Acceptable? 70 maybe? Probably 70.
Can you send 70? Actually, this is what 70 people looks like.
It's my family.
So now, what do you think would be a more acceptable number?
0. 0.
Na verdade, é isso. Nenhuma morte por trauma ela pode ser considerada aceitável. O trauma é uma causa de morte 100% evitável. E nós precisamos lembrar disso. Era isso que eu tinha para falar. Muito obrigado a todos.
Thank you, Professor Rodrigo Caselli. So I'd like to invite for the next presentation Dr. Emujaga Iramaura. He's from South Africa, and nowadays he's in Scotland, and he'll talk about trauma prevention, public health approaches.
Boa tarde. Firstly, I would like to thank the president of the ANM, academic ELIETE BOUSKELA, for the invitation. Secondly, I would like to thank the meeting organizers, José Camargo, Rossano Fiorelli, and Professor Gustavo Fraga. Making trauma surgeons obsolete, trauma prevention. So public health approaches to trying to tackle the burden of trauma that we've just heard about from my colleague. My name is Diaga. I'm a general surgery resident in Scotland and a surgical skills simulation fellow and a fellow of the Surgical Education Research and Innovation Lab at the Royal College of Surgeons of Edinburgh. I've spent time in my career in South Africa and at the UK's highest volume major trauma centre for penetrating trauma. I have a master's in trauma sciences and I have a degree in global health from Imperial College London. So this talk is a bit about joining those things together and thinking about how we can get to that zero number. I have no disclosures. The public health approach to tackling trauma. I want to tell you a parable. It is not mine. It is a very famous one, and some of you may have heard it. Professor Zola, medical sociologist, is first described with crediting the term refocusing upstream. And I want you to hold this story in your minds when we move on to thinking about trauma. I am a trauma physician. I am standing by the shore of a swiftly flowing river, and I hear the cry of a drowning boy. So I jump into the river, I put my arms around him, and I pull him to the shore. And I begin resuscitation. When he begins to breathe, there is another cry for help. So I jump into the river, reach him, pull him to shore, and again begin resuscitation. And then, just as he begins to breathe, another cry for help. So back into the river I go. I'm so busy jumping in and pulling these patients to the shore, doing the same over and over again, that I have no time to see who is pushing all of these people into the river upstream. So the approach that we could consider using in trauma is refocusing upstream, trying to take a step back to consider what can we do to prevent trauma. We've heard very recently about some of the common causes of trauma in Brazil, and these tend to be mirrored globally. These are the 5 common causes. A lot of people in this room are trauma surgeons or work in the trauma space as anesthetists or emergency medicine physicians, intensivists, or educationalists. With the idea of refocusing upstream in mind, I want you to start to think about some of the conditions and what interventions we can make with an upstream focus to reduce the impact downstream. For example, when considering motor vehicle collisions, we can make our roads safer by reducing drink driving, ensuring seatbelts are worn, ensuring helmets are worn when somebody's on a motorbike, and reducing and enforcing strict speed limits. When it comes to falls, which is an important part of what causes trauma, often in the elderly, falling from standing can be catastrophic. So improving home safety and enhancing physical strength and balance and addressing potential medication side effects can have a really big impact. Workplace accidents play a big part of what contributes to trauma, and engaging and embracing health and safety legislation has the potential to reduce the burden of trauma. With burns, we can work with manufacturers on safety and engage with smoking cessation campaigns. With interpersonal violence, a public health approach can be incredibly useful. And I've been lucky enough to work in 2 trauma systems where they have adopted a public health approach to tackling violence. And these have worked very successfully. The first example is the Scottish Violence Reduction Unit. It's a community initiative to reduce violence, and it's led by the Scottish Police. It's not led by the government, it's not led by the healthcare, it's actually law enforcement. And they've drawn on the work done in Boston and in Cincinnati to try and implement something that works. They believe that violence is preventable and not inevitable. Their approach is threefold, and it does include law enforcement, but it also includes providing services and programs that can help individuals and steer them away from violence. And finally, they work within the community. Their approach requires collaboration. This is collaboration between Police Scotland, the social services, the education department, and charities like Medics Against Violence, which is made up of healthcare professionals and students. The public health approach is very utilitarian, so it tries to affect the greatest benefit for the largest number of people. And this is different to the individual healthcare practitioner treating one patient in the trauma bay or in the operating theater or in the intensive care unit. Both of these are important, but one has a greater capacity to save lives. Public health solutions have to be interdisciplinary and evidence-based also, bringing together the experts in medicine, epidemiology, sociology, psychology, criminology, education, and economics. And through this, it can be possible to implement changes that save lives at the upstream, reducing the amount of work that healthcare professionals have to do downstream. Cooperation between organizations and individuals in health, education, social services, justice, and policy are necessary to solve problems in trauma. Step one is mapping the data, and we've just had a very impressive talk about the epidemiology of trauma in Brazil. Step two is about interrogating the why and what the causes are and what factors increase and decrease the risk of interpersonal violence, but also what we can change. And we can think about this on a local level or a global level, as we heard in the first speaker. Step three is our interventions. And I'm going to talk a little bit more about what I've learned from my experience and how interventions can work effectively slightly later on. But our starting point has to be that the belief that violent behavior and its consequences can be prevented. The second example of an intervention to help reduce the impact of interpersonal violence is something I came across whilst working in the major trauma centers in the London major trauma system. Firstly, as an emergency physician, and then as a trauma surgery fellow. Both of these major trauma centers had access to third sector organizations, so charities effectively, that would intervene and meet individuals who had been involved with or experienced trauma as a result of interpersonal violence. And they would offer their support to help prevent this happening again. They would work with individuals to find out what were the push factors that led to their situation and offer support with housing, finance, education, relocation to take them out of their environment, healthcare, social care. All of these things allowed them to avoid becoming involved in violent situations again. It was incredibly inspiring to see this work. And it meant that when somebody underwent a trauma laparotomy for an IVC injury with renal vein damage and a duodenal injury with liver laceration and a gallbladder injury, this one patient would then go on to not experience this again. I want you to take a short moment to think about some of the experiences that you may have had with trauma in your own clinical environment and try to consider if there is anything that could be done upstream to reduce the impact in your day-to-day work. I hope that you managed to think of some. I said that I would come to talk about implementation, and from my own experience and from my reading, I think there are a number of incredibly important things that go into making a successful program. Some of the common themes of successful public health interventions for managing trauma are an awareness of and working within some challenging concepts: culture, context, collaboration, and communication. Having an understanding of the culture within which you're working, whether locally or globally, and creating a culture that embraces refocusing upstream is incredibly important. The context of your intervention matters. Something that works in Scotland will not automatically work in Brazil. Therefore, having an understanding of one's own context of practice is incredibly important. And finally, collaboration and communication. Working with others, either on the individual or organizational level, to bring about change is key. This is something that I learned not even through medicine, but through community organizing work. This communication between individuals, but also the communication of successes and failures to wider audiences is incredibly important, so others can learn from your experience. I have two questions for you. This meeting is about multidisciplinary trauma management. Do you have a public health specialist as part of your trauma team? Is the first question. And if the answer to that is no, would you consider having a public health specialist as part of your trauma team? Because the work that can be brought about through taking a step back and refocusing upstream can improve the health of many. Will trauma surgeons become obsolete? I don't think so. I think that there are enough young men like myself who will do silly things like ride motorbikes and look for fast cars, that there's always going to be a need for trauma surgeons. But we can avoid and reduce the burden of trauma and reduce the amount of work that trauma surgeons need to do. Thank you very much for listening to my presentation and for inviting me here. I look forward to hearing the next speaker.
Thank you, Dr. Jaga. We have time for questions at the end of our lectures. So let's go for the next presentation. I'd like to invite Dr. Arthur Zanelato. Dr. Arthur Zanelato was graduated at the Universidade Federal Paraná, Curitiba, some years ago. 20 years ago, he went to work in UK. In the last 7 years, he has worked at University of Edinburgh, Scotland. He's a good friend of yours. He's a Brazilian, and he'll talk about how to train the surgeon.
Boa tarde a todos. Excelentíssima senhora professora doutora ELIETE BOUSKELA, ilustríssimos acadêmicos, professor Rossano e professor Gustavo Fraga, caríssima audiência e caríssimos senhoras e senhores, um prazer imenso estar aqui falando nessa instituição de tanta história. Como está no meu primeiro slide, nós temos aqui o Dom Pedro, que é o fundador da academia, que tomou a liderança para começar essa academia e ter um ponto fundamental na educação médica no Brasil em 1829. Muito obrigado pelo convite e me sinto muito honrado de estar aqui hoje. Eu vou falar em inglês para que os meus colegas estrangeiros possam entender. How to train a surgeon? Well, first of all, you can born with the drive to be a surgeon, or you can born and we can try to make you a surgeon. But if you're born with the drive, it will be much easier. And of course, the one that doesn't born with the drive, we can train, but we'll never reach the excellence as the other one. They have different abilities. So medical school, there is a lot of similarities between Brazil and UK, and I'm gonna present you the differences. In the end, we're gonna find out what we could improve in Brazil from the things that are good in UK. It's not perfect in UK, but there are a lot of things that we can bring from UK and from Europe. Of course, there are things in Brazil that can be brought to Europe, like me. The post-graduation, the internship foundation. So in Brazil, we go straight from the medical university to the residency. So the training, either surgical or medical pediatricians. In UK, once you finish the medical school, you have 2 years of foundation years. That this is pretty much what is our final year in the medical school. Oh, let me come back. So, and the initial surgical training. So in Brazil, there are some leagues of trauma that start the training when you are a medical student. So you start much early. Already in the medical school, you go to the you attended the emergency department, the surgical theater to learn. And that is something extremely good in Brazil. And we don't have access for the medical students as we have in Brazil in such an organized way of medical leagues and trauma leagues. Then the final year, the medical course, we have like either 3 or 4 months surgical rotation. That is very short rotation. In UK, these 2 years of foundation year associate with the core training, give you a quite robust foundation to go to the surgical training. And you still need to do an exams that we call MRCS. So in the higher training education, so in Brazil is 3 years, the general surgery, and plus 2 years for subspecialty training, and is non-compulsory, non-compulsory to have the specialist training in Brazil. With 3 years, you can get the registration as a general surgeon, which is good if someone is gonna leave the capitals and the big cities and going to work in a very small city in the countryside, in the states that we have a really poor and difficult access to the healthcare. In UK, the training is 6 years and 2 in the chosen specialty, but this is compulsory. In the end, you have the FRCS examination that is again apart. So putting this is in a column, you can see the differences. We have a very speed way to finish, so much shorter. So putting a line, we have a big jump from the medical school going straight to the training, and we have this non-compulsory obligation to go for the specialist training. Again, 2 exams, MRCS and FRCS, to go ahead. So the difference is 5 years training. How we regulated the training in Brazil and UK. So in Brazil is regulated by the Minister of Education. And the Minister of Education is composed by a large number of people with a very small participation of the surgeons. The regulation in UK, so the training specifically for surgery I'm talking, is all done by the Royal College of Surgeons. And this is regulated by the General Medical Council. So the Medical Council give you the freedom and the responsibility to the College of Surgeons to organize the training, but also check if they are doing a good job. So it's a good relationship. So how we do the evaluation? So for the foundation year, we have these tutors. Someone that is interested, I suggest you go to the website. You can read and can see all the guidelines, what is expected from the foundation year, and the portfolio that they must have at the end. Same, the ISP, that is in the Intercollegiate Surgical Consortium for training, for the high training, you have all the standards that you need to follow, and is the same from dental, orthopedics, all subspecialties. You can have this. So, and then when you become a surgeon, then you also need your evaluation, because we never stop learning. I have 32 years of as a surgeon, and in UK, I go through assessment every year, and I also do assessment of my colleagues. I do appraisals, and I appraise the others as well. So again, we need to check if the trainer is doing a good job. So salary is not something that we need to pay much attention, but is just to highlight it, that you need to pay nicely the trainees, the residents, because they need to have support to carry out the life. If someone is stressed to finish in 3 years, to become their profession, to pay the bill later, they want a short training. So if the government is able to give support to the trainees, they will have the peace of mind to go to a long training. That will be ideal. The other thing that there are support in UK for courses, and the study leave is different than the annual leave. So the time that you have to go on a course, in a conference like that, is not taken from your holiday. So the life balance is better. Examination certification. So in Brazil, when you finish, you go straight to the Ministério da Educação, and you present your documents, and that is registered. In UK, you need to go for the examination, and that's a very tough part of that you need to go through. The format of the FRCS examination, you have 2 sessions. So the first session, you need to read a paper and give the best answer. You need to go through several questions. And then the other one is a clinical component where you go face-to-face with 3 assessors, all the specialties. And once you have succeeded in this part, then you can go for the registration in the GMC. Another difference is that the council in UK, we call General Medical Council, it's applied for 4 countries, Wales, England, Scotland, and Ireland, North Ireland, which means that is 1 council for the whole country, and the intercollegiate that do the assessment is for the 4 countries. Here we have only 1 country divided in several states, and every state has their council. So the clinical exposure and the operative experience. So Brazil has something very interesting, that broad exposure to the trauma. I can say that is fantastic because I was trained in Brazil, and my training as a trauma surgeon in my first year as a trauma surgeon gave me such a competence to go to any country and work and have a very good results. But the training in UK is a little bit more structured and case load with a logbook, less open trauma experience, but you go through all the specialties, and you have the exposure in the other specialties that might cover a little bit. Doing a big hepatectomy for a cancer might give you a little bit of competence to see a trauma, a liver trauma, or if you pass some months in the cardiothoracic, that will give you some competencies to go to a trauma, but it's a completely different situation when we are talking trauma. So working hours versus lifestyle. So Brazil is unregulated hours, is a high workload. We say that is only 40 hours per week, but we know that in the end of the day, the trainees, they end up with much longer hours. In UK, the hours are regulated. Thank you. Up to 48 hours per week. It's not moving. Okay. So pros and cons. The comparison between a competency-based versus time. So in Brazil, it's faster progression and broadly early exposure. So in UK is longer, but well structured and better life balance. In summary, Brazil is faster, the certification, but less structured and is non-competency based. And that's that I want to call the attention, because this is a political problem. In UK, it's longer, but it's standardized with defined milestones and competency base, which means you must have 100 laparotomies, you must have few cholecystectomies supervised, few cholecystectomies with less supervision, and you have some cholecystectomies with minimal supervision as first consultant. And this is a logbook that you register all your procedures that you are done. And if you reach the 10 years training, that is the longest in the world, you won't be able to apply because you don't have the numbers of the operations to apply. What's happening in Brazil? We have the UNICAMP that is represented here today by Professor Gustavo Fraga, where they have a fantastic system to train for many years, established by Professor Montovani. And they have a very nice structure for training trauma. But if you go to a city in the interior of Paraná, Cascavel, Londrina, is the case load exactly the same? They have the same exposure? Do they have a problem in Campinas or in Hospital do Trabalhador, where I was the trainer? We had like 4 laparotomies in one night for open trauma, more 2 thoracotomies. But if you go to another hospital, they have 1 laparotomy per week or 1 thoracotomy in a month. Thank you, sorry. I'm gonna close. So I bring the Hippocratic Oath, where we need to look after our trainees and take them as our family and look after them. Thank you very much.
Thank you, Professor Arthur Zanelato. Now I'd like to invite Dr. Henrique Alexandrino. He is from the University of Coimbra, Portugal, and he is the president of the AUTEC, Associação Lusitana de Trauma e Emergência Cirúrgica. He will present the lecture, How to Train the Multidisciplinar Team. Just remember, the title of the symposium is Trauma and Acute Care Surgery, the Multidisciplinary Approach.
Muito obrigado. I'd like to first salute Honorable President Madame ELIETE BOUSKELA, academic leader, president of the Academia Nacional de Medicina, dear panel members, dear academicians, dear colleagues, ladies and gentlemen. I'd like first to thank the distinguished honor of having this presentation. And I'd like to start with my affiliation, my hometown, Coimbra, one of the oldest towns in Portugal, strategically located in the banks of the Mondego River, a long-term settlement from the Romans, and the capital of what was the predecessor of Portuguese, the Condado Portuguese. This is my university, my alma mater. It was the second oldest university in Europe after Bologna. And UNESCO World Heritage Site, one of the top 500 best universities. This scenic room, Sala dos Capelos, Biblioteca Joanina. And this is my hospital, the Coimbra University Hospital Center, one of the largest hospital units in Portugal, with over 2,000 beds, and a level 1 trauma center for 2 million inhabitants. This presentation, I've decided to split it in 3. And the main goals are why we should train the multidisciplinary team, how we can train the multidisciplinary team, and how are multidisciplinary teams being trained currently in the world. So to answer the first question, I'd like to leave you with a challenge. And the challenge is, if you would see this promotion on searching the internet for a flight, you would come across this quite cheap flight, only Rio de Janeiro to London, on less than 200 reais. And everything is apparently perfectly fine. The airplane is in top condition and the crew members are technically outstanding, but there is a catch. Would you like to know what this catch is? And the catch is that the pilot and the co-pilots do not work well as a team. They have problems in communication with each other and with the control tower. And for a bit less than 200 reais, would you take this flight? And the issue is that we demand that the people that fly us, us and our families, when we are traveling by plane, and to those that coordinate all these activities in the ground control, we expect extremely high levels of multidisciplinary work, extremely high levels of non-technical skills and communication. Why should we not have the same level of commitment and demand from us, from medical doctors and nurses that are in the teams and take care of the sick patients in the emergency conditions? So the issue is that trauma and operating room teams are action teams. They assemble immediately, most times without warning. You have to recognize that emergency rooms and operating rooms are scenarios, are contexts where there is a very high rotativity of the staff, and the members may not know each other, may have never worked each other together, have different backgrounds, have different skills, and will immediately have to perform life-saving decisions and tasks. So this is a perfect storm for poor errors, and for poor outcomes. And this brings us to the issue of human factors, meaning that how professionals interact with each other, with technology, how they gather, interpret, and act on information. And this is, in fact, one of the main issues, main cause of errors in medicine. The main errors are concerned not with technical issues, not with issues related to our own practice, but they're related to these issues with communication and leadership. And these errors, these non-technical issues, are more likely to occur in scenarios where there is a very high importance of communication and non-technical skills, meaning the operating room, the trauma scenario. And not only are they more frequent and more likely to occur, they will have the most severe consequences. And it is known that the trauma patient mortality can increase by fold or fourfold in case of a non-technical issue. Como é que eu passo? Yeah. So, okay. So this is extremely important because we recognize, and although these issues are important and they are relevant in the way that they cause mortality, we know that team training will decrease mortality. This is a quite interesting example of a setting where in the yellow line, a hospital that did not implement trauma team training versus an hospital in the same period of time that implemented trauma team training. And the purple line shows a clearly decrease in mortality, especially in the most severe cases. This applies not only to trauma teams, but to surgical teams, operating room teams, whereas this also been demonstrated in the literature that programs that implement operating room training for surgeons, anesthesiologists, and nurses will have an 18% reduction in overall mortality versus 70% decrease in the same period of time in the centers that did not perform. So we see a 9% difference And I wonder, would we not like to implement something that would bring a reduction in 9% mortality to our patients? Most of us or all of us would surely would. So this brings to the issue of non-technical skills in emergency and trauma. What are they? They are cognitive and social skills that relate to the performance of tasks and how humans interact with each other. We have several examples of several training programs that can develop and work on these non-technical skills. One of these, I would say, with the paradigm of non-technical skill training is the European Trauma Course. European Trauma Course is a European course that is designed for the trauma team members in trauma centers. That is particularly, I would say, not competitive with the ATLS program, with the Advanced Trauma Life Support program. It is complementary because it develops on the clinical and decision-making skills and technical skills of the ATLS program and works on them, providing the candidates, the participants, with the possibility of developing their leadership skills and the ability to promote non-technical skills and addresses teamwork and communication. So, but what happened next? What happens after the patient leaves the trauma bay? He goes to the operating room. And there are also training programs in this. The DSTC, Definitive Surgical Trauma Care, Definitive Anesthesia, and Definitive Perioperative Nurses joint courses that we do in Portugal are a realistic opportunity for immersion in a trauma scenario, in the trauma operating room, in a simulated scenario, where candidates and participants will develop not only their technical skills and decision-making skills, but also their teamwork. And in the long-standing contribution, the collaboration that we've had with the Brazilian group, we have studied that both courses, Definitive Surgical and Aesthetic course, did really improve the participants' self-reported importance on the role of communication. Luckily, there are other programs, and I'd like to recognize this really relative addition, recent addition to at least to me, because I had the opportunity to participate in the second Brazilian course, the non-operative skills for surgeon, non-technical skills for surgeon, which I believe is an excellent example that should be mandatory for residents and medical students in the way that it shows how these non-technical skills are relevant and will surely make a difference. But you don't have to go for this the distinct courses. You can also do this yourself. And I bring the example of our own trauma team training program that's developed in the Coimbra University Hospital Center for the past 4 years. It's a one-day simulation. We train doctors and nurses of the medical staff of the trauma team. We train them like we used to in very similar scenarios that resemble our emergency room. Our motto is simulate like we work and work like we simulate. And at the moment, we have over 24 editions, and we have trained over 300 professionals, doctors, nurses, and we have recently added doctors and nurses of the blood bank, which are also members of the extended trauma team, and radiology technicians due to their importance in recognizing the path of the trauma patient. But what is the real world data on trauma team training? How are teams being trained? How are we managing to do this? Well, we also did an international survey where we are extremely happy that we had many responses from Brazil. And the results are that although most of the respondents, and again, there is a bias of the response because this is a voluntary survey, that people believe in the importance of trauma team training, only 33% of hospitals have trauma team training programs, and only a quarter of people, of respondents, had non-technical skills training in their undergraduate level. So, but not all is bad news. We know that this can be applied to students, and not only can be applied, it should be applied to students. We've studied what happened with a group of 12 students over one semester, 6 months, and we realized that having a dedicated program in non-technical skills, medical students will reach high level of competency in non-technical skills, and will retain 1 year later this high level of competency in non-technical skills. So we really should consider what kind of medical doctors we would like to train in the end. Are we training an isolated trauma doctor, an isolated doctor who is excellent at these skills? Yes, we should, but we also train trauma. We should also train team members, because team members will be excellent team leaders. Speaking of leaders, I would like to show my last affiliation, the Lusitanian Association for Trauma and Emergency Surgery. We're a very small community. We're This is our Board of Governors. We are now celebrating 20 years. We are extremely happy because we're fortunate to have a twinning agreement with the Brazilian Trauma Society, SBITE, and we're institutional members of Estas, which I think is extremely important because it demonstrates that through community and sharing and collaboration, we make ourselves better. And we have a history, a very fortunate history of collaboration in training with Brazil, especially in team training, not only with the STC courses that were started with our community in 2010, but also with the European trauma course and the joint definitive surgical and trauma anesthesia and surgical care courses. Now, just before the end, thank you. Just before the end, this is a statement of what value of collaboration this is. And this is not by chance, because we have I would say, luck of having two great leaders at our helm, Dr. Carlos Mesquita and Professor Gustavo Fraga. They've been true leaders. They've been the dreamers and the doers of this, I would say, long-standing collaboration. And we, in our society, we believe these prophetic, I'd say, very interesting words by the Greek poet and soldier, Archilochus, that in a crisis, we do not raise to the level of our expectations. We fall back to the level of our trainings. And as such, ladies and gentlemen, I'd like to thank the opportunity and leave you with open for questions. Thank you very much.
Thank you, Professor Henrique Alexandrino.
I would like now to invite academic Otávio Pires Vaz for comments, please.
Excelentíssima presidente da academia, ELIETE, BOUSKELA, nossos Rossano e o Gustavo pela excelente organização desse curso. Very important topics were brought today for our attention, and I will point some that I think that was very, very important. First of all, the road traffic are still one of the most causes of death and trauma in the 21st century. The second is the worst, I believe, is the war. The war shouldn't be brought to this section, to this meeting. It's unfortunately we are having this problem in the 21st century. We shouldn't have it, but we are. So we have to be realistic. It's very important, I mean, how to train a surgeon. I've seen a lot of courses and a lot of different ways to train a surgeon, but we have to be realistic in Brazil. The trauma surgeon in Brazil, they don't live doing trauma. Trauma is doing on their spare time. They are surgeons, they work in the public hospital, in the private practice to have some decent amount of money to live. And during the spare time, they go to the emergency room and do trauma surgery. So we've seen that nowadays that the government are allowing a lot of different universities of medicine being created. I don't know how it's going to be a surgeon, how is going to be trained a surgeon to attend the magnitude of trauma that we have in Brazil, which it's still very high. Our traffic accidents, our bullets, people that are being killed on the streets, especially in Rio de Janeiro right now, São Paulo, they are big cities, and this is something that is almost out of control. The one thing that I have that I think that it's also very important is to how do you rescue the people that are, that have a trauma in the streets, for instance. How long does it take for you to get this guy it takes to the hospital and for it to be attended. We have seen nowadays in Taiwan, a Brazilian that died, that if they had a better rescue service, probably she wouldn't have died because she took some time for her to die. And during this time, we could look at her, but we could do nothing. And nothing was done, and she died before she had been rescued for the hospital. We still don't have that. It's better right now, but we still don't have a rescue system in Brazil adequate to the amount of trauma that you have and the magnitude of trauma that you have. So I believe that meetings like that should be very frequent, and should something be written for all of us and sent to the government, because in Brazil, who decided how we're going to train a trauma surgeon never did a trauma surgery, never. There are politicians or there are people that belongs to a committee, and they never did a trauma surgeon, but they think that they are capable to decide how to be trained a surgeon to attend people that go to the emergency room. And we know that, to be a trauma surgeon, I did that for a long time. I did thorax, cervical, abdominal. I did a lot of complex problems. Nowadays, the trauma surgeon has to do ultrasound. And how many surgeons in Brazil do ultrasound? I don't know. Probably very few. Very few. Very few can do an ultrasound in the emergency room. We have to count on the radiologists to do that. It takes time for the radiologists to attend all people that are traumatized in the emergency department. So we are facing very complex problems to train a trauma surgeon. And unfortunately, this is still a big cause of death that shouldn't be happening in this time. Thank you for each of you that did a very nice presentation and brought this subject to our attention. Thank you very much.
So just congratulations for the speakers. Excellent presentation. It's like a global scenario to have an idea about this disease. I try to speak in English. Forgive my English is not so good, but I think it's important for our international guests to understand what we're having this afternoon at Academia Nacional de Medicina. Unfortunately, Brazil, I think now has the highest number of medical schools in the world. Used to be India, but with Demografia Médica 2050, you have a report scenario. You have in Brazil 448 medical schools. It's not good because the last years, so many medical schools, private medical schools, they are preparing physicians, doctors to work, and some of them, they don't have a structure to have a good physician. This is a big problem for us, for our population, because many schools don't have the quality to give a good conditions to have an excellent physician. Another problem is about the residents. The best way to train a professional physician who wants to apply as a specialist is about medical residence. And you observe here the difference between Brazil, where you have 3 years, only 3 years as general surgery. In Scotland, when they have 7 years. In the other countries, at least 5 years. So after 3 years, the general surgeon in Brazil can apply for other areas like urology, vascular surgery, plastic surgery, pediatric surgery. And there is the option to apply for trauma surgery. The problem is the program about trauma surgery. I did this program at University of Campinas, 1995, 1996. 2 years. I trained 2 years with Professor Mario Mantovani at UNICAMP, because this was my option. I had the opportunity to become a digestive surgeon, a plastic surgeon. I had the opportunity to become a neck and head surgeon, but my option was to do trauma surgery. Because 25 years ago, I had some professors that used to go to different congress, big societies, explaining for young guys like the students who have in this auditorium that trauma is a problem. 20 years ago, trauma is a disease. You need young people to take care of this disease in our country, to develop strategies with the academies at the universities, strategies with the societies, and strategies with the governor. You need to work together to improve the care of the trauma patients. In Brazil, we have a good pre-hospital system. The pre-hospital system started in Brazil 2002. A lot of decisions came from the governor, like SAMU, and you have the firefighters. Rio de Janeiro, very well organized pre-hospital system. The problem, when you have a motorcycle crash, every day you have this problem. You take the patient to a hospital where you don't have structure to treat the patient. The emergency department is overcrowded. The physician who is there don't have training to treat a critical case of trauma because there was no resident for this specialist. So you need to change. General surgery is totally different of trauma surgery and acute care surgery. The idea to discuss about these topics with our international guests is to show for the Brazilians that you need to change the way that you prepare the trauma surgery in our country. The epidemiology, it's very evident that it's a neglected disease in our country. Totally neglected. The government, they know about this. So you need to improve the quality of the physicians who take care of the trauma patients. Like ultrasound, a good trauma surgeon, he needs to have total skills to perform an ultrasound in the emergency department and at ICU. A good trauma surgeon, he needs to work with prevention. We have a strong program called Trauma Leagues in Brazil. Everyone in this room went to a congress, World Congress of Trauma and Emergency Leagues. 1,000 medical students and nurse students work together, showing to them 19 different countries were in Campinas, how the students can work with prevention. Dr. Rodrigo Caselli told us that prevention trauma, you can save at least 90% of the events to reduce the events. You have a critical problem in Brazil nowadays is a motorcycle. You need to discuss how to save the life of these young motorcyclists because it's a big problem. But if you go to the hospital, the physicians are not prepared to treat the patients. So I'd like to thank you the opportunity to discuss this topic here at Academia Nacional de Medicina. Thank you, Dr. Rossano Fiorelli, who is a thoracic surgeon, but worked with trauma. At least the last 20 years, we are together organizing a meeting and trying to bring the young students, the residents, for this area. It's very difficult to work during the night, on calls, the weekends, but it's an option. I did this option. And my mission is bring the new generation who wants to learn about trauma. I think you have a different professor from different countries here who can open the doors, give opportunities for you. Thank you.
Some questions? I have time for questions. Comments?
I'm really delighted. I'm really delighted to have all my colleagues. We never worked together. We met in Brazil recently, but you can see that people that live in different countries with different backgrounds, different training, and different perspectives of the trauma, they came here and they delivered the same message. So we need attention to the trauma because this is a disease. We need specifically training. We needed to tackle the problem, like Diaga mentioned. If we keeping just treating the trauma without close the tap and stop the water running and flooding the bathroom, we'll never stop the trauma. We have I explain how is the training, but in summary, what I summarize my presentation would be just that we need a specifically training for trauma, because if it's an epidemic pathology in Brazil, we need a specifically training, a specifically surgeon. And I'm very pleased to see the work that you have been doing here today and during this conference, and with all the academics that is underfunded to bring ideas, to bring solutions from very underfunded. So that's need attention. That's need really people fighting together. So when you put all these gentlemen together, all these colleagues together, I apologize to the ladies, gentlemen and ladies together, we can do better. We can do better. It's not for one to fight for one. And I finish my comment with that very, very interesting moment of the gladiator move. When the Marcus Aurelius, he say, if we stay together, we'll survive. Doesn't matter what is coming from that door. We need to stay together.
O Rodrigo Caselli.
Boa tarde. Eu gostaria de tentar responder o questionamento do acadêmico com relação ao que podemos fazer, com relação ao treinamento dos nossos cirurgiões para poder enfrentar essa doença. Acho que de tudo que foi apresentado aqui, ficou muito claro que nós estamos falando de uma doença específica, uma doença que tem uma fisiopatologia própria, que tem um tratamento próprio, que tem vários treinamentos próprios, específicos, tanto do ponto de vista de equipamento, de material, você falou do ultrassom, entre outras técnicas, entre outras habilidades, habilidades técnicas, habilidades não técnicas, tudo isso faz parte de um rol de conhecimento que, no nosso entendimento, se resume em especialidade. Se é um profissional que precisa dominar todas essas áreas de forma diferente de outros profissionais, Isso nada mais é do que entendido na nossa área como uma especialidade. Assim o é na neurocirurgia, na cirurgia oncológica, na cirurgia cardíaca, em várias outras áreas. Existe um mau entendimento ainda, até hoje, de que trauma é uma doença que todo cirurgião sabe lidar. Os números mostram há muitos anos que isso não é uma verdade. E nós temos no Brasil uma história recente por onde trilhou a medicina de emergência. Durante anos se entendeu que emergência, todo médico sabe emergência. Todo médico deveria saber emergência. O que nós precisamos é melhorar o treinamento dos médicos para atender a emergência. E o mundo já tinha mostrado que isso não é verdade. Que em muitos países a medicina de emergência já era uma área específica que exigia treinamento, habilidades próprias. Em 2015, a medicina de emergência se tornou uma especialidade no nosso país. E para quem acompanha, para quem conhece esse envolvimento, essa evolução, nós vimos o quanto a medicina de emergência evoluiu nesses últimos 10 anos. Em termos de organização, em termos de estrutura, de profissionalismo e de melhoria, de capacitação e qualificação do seu corpo clínico. Então, nós entendemos que o trauma já passou da hora de se tomar essa providência. 150 mil pessoas morrendo todos os anos há mais de 10 anos. Nós não podemos continuar desse jeito. E nós entendemos que a criação de uma especialidade, de um entendimento que esse profissional é treinado, capacitado para esse fim, é uma das maneiras mais eficientes que a gente tem de resolver. E muitas vezes, alguns dos argumentos contrários dizem o seguinte: nos Estados Unidos não é especialidade, na Europa não é especialidade. Sim, mas todos aqui vimos a diferença da formação e da qualidade do cirurgião generalista na Europa, nos Estados Unidos e no Brasil. Então, algumas experiências estrangeiras não se aplicam à nossa realidade. A nossa residência básica, a nossa formação básica em cirurgia geral ainda está muito aquém da necessidade que a nossa população tem. O que dirá para o trauma, que é uma doença que precisa de conhecimento, de decisão rápida. Então, nós entendemos que uma das formas que nós temos de tentar reduzir esses números catastróficos que nós temos é a criação de uma especialidade, o entendimento da especialidade como cirurgião de trauma e emergências cirúrgicas. Obrigado.
Obrigado, Rodrigo. Dá mais um tempo. Estou siciliano. Quer fazer algum comentário? Não. Ok. Então, let's choose second part. Education in Trauma and Acute Care Surgery.
Antes de começarmos a segunda parte, eu gostaria de chamar para tomar assento à mesa o acadêmico Alberto Schneider, por favor.
Não. Yes. Okay, I invite to Professor Rodrigo Vaz Ferreira to talk about advanced trauma life support, what's new in the 11th edition.
Boa tarde a todos. Meu nome é Rodrigo e gostaria inicialmente de cumprimentar a excelentíssima senhora presidente, doutora ELIETE Bouskelas, em nome da qual eu cumprimento os outros excelentíssimos acadêmicos. E estou aqui para conversar com vocês. Perdão. Não está passando aqui. Para falar com vocês sobre a 11ª edição do ATLS. So, I just wanted to say I'm sorry and my apologies for not doing that talk in English, because I think that the main target of ATLS is the students and the youngest one. So this is why I'm going to present this in Portuguese, if that's okay. Eu sou hoje o Country Chair do Committee on Trauma no Brasil e, naturalmente, o meu disclosure é que eu represento os cursos, né, de ATLS, o PHTLS e outros cursos no Brasil. Então, a minha conversa pode nascer desse local. O ATLS, então, para a conversa que alcança alguns de vocês que são mais novos, né? O ATLS é algo que surgiu no final dos anos 70, no início dos anos 80 e veio parar nos dias de hoje. Nasceu em Nebraska, né? Lá naquele acidente do Dr. Steiner e depois foi parar no resto do mundo. Mas as mudanças que foram provocadas no ATLS até essa 11ª edição saem de um livro que era um manual de um pequeno local e que virou um livro de cabeceira, um bedside book. E aí é de onde essas conversas surgem. Então, por isso, eu não estou aqui para justificar, mas é importante que a gente contextualize, né? Então, para falar um pouquinho sobre o processo, o conteúdo e a flexibilidade que são características dessa 11ª edição, primeiro falando sobre o processo, esse processo é um pouco diferente de outras edições anteriores no mundo, foi mais global. Então, foi de esforço global, mais de 24 grupos de conteúdo, mais de 200 pessoas envolvidas e mais de 20 países representados na construção do texto do ATLS da 11ª edição. Naturalmente, isso tudo tomou um pouco de tempo a mais do que o previsto até, mas traz impressões diferentes das edições anteriores, em que a gente não tinha tanta representatividade, talvez, do resto do mundo. Falando, então, das grandes mudanças, o que era diferente, hoje o livro, o texto, essa 11ª edição, ela tem 3 componentes principais, que a primeira delas é sobre avaliação, manejo e a ressuscitação do paciente vítima de trauma. Uma segunda parte, e aqui tem uma grande mudança, né, contextual, que é de trazer assuntos relacionados aos sistemas de trauma e ao cuidado centrado no paciente, e uma terceira parte última, que é das lesões específicas dos padrões de lesão. Então, agora, isso é como é a distribuição dos capítulos e as grandes mudanças da 11ª edição. Pela primeira vez surge, na sequência, o atendimento que coloca o tratamento da exsanguinação antes da letra A, da letra B, da letra C, como a gente conhecia até a 10ª edição. E aí ficou o XABCDE, que é uma corruptela do PHTLS, né? Os capítulos, então, o primeiro capítulo que abre o livro é um capítulo sobre Initial Assessment na Primary Survey, que é a avaliação inicial. E na sequência das coisas que acontecem, lá no 14 marcado, a gente vê a Secondary Survey, ou a avaliação secundária, como um tema que apareceu na sequência. Então, a sequência mudou um pouco e ela fica mais inteligível e mais compreensível para o novato, né? Para a pessoa mais jovem no processo de aprendizado de trauma, né? Então, essa é a grande novidade em relação ao surgimento, né? A letra X. E a gente tem aí agora capítulos que foram trocados, que antes eram de trauma torácico, ou trauma abdominal, ou de trauma raquimedular, por exemplo. Agora não, agora você tem um capítulo de letra B, letra C, letra D e letra E, o que coloca as coisas no lugar da forma com que isso é ensinado no planeta todo, né? Essa aqui interessa muito, eu acho que o Dr. Gustavo e outros tantos presentes aqui têm muito interesse em ver isso, que é o surgimento de um livro, de um manual como esse, de um livro como esse, dessa segunda sessão que fala sobre sistemas de trauma. Que isso não é exatamente inovação, porque isso já existia antes, mas no livro, como tema importante colocado dentro, isso é uma novidade, isso faz muita diferença, porque a gente já devia estar discutindo sistemas de trauma há bastante tempo no Brasil, e a gente não devia estar discutindo apenas o atendimento inicial ou a doença. E aí agora isso é um pouquinho diferente. A gente tem aí um capítulo e tivemos uma fala excelente sobre prevenção da lesão, do trauma. Então, agora tem um capítulo sobre prevenção de lesão, assim como outras coisas novas, como o capítulo 19 e 20, que tem a ver com o consentimento informado, comunicação de más notícias, coisas que a gente não tinha, porque o paciente virou o centro da atenção e isso não existia antes. Então, a gente tem aí diversas coisas para colocar, né? Então, das novidades do curso, de como a gente conversa, a gente fala sobre site names, então a gente fala o nome das pessoas, a clareza da instrução e a comunicação em alça fechada. Então, isso tudo não era ensinado antes. A gente tem representantes aqui de curso que falam sobre atendimento em time, já comentava isso antes, mas no ATLS isso é uma novidade, é uma coisa que não era colocado. Então, essa é uma evolução, acredito, e muito importante do curso, né? A gente tem acrônimos e modelos propostos para comunicação antes do recebimento do paciente. Então, tem o Team Huddle e como é que a gente se prepara para receber. A gente faz esse task assignment, que é, o que a gente vai fazer, você vai fazer isso, você vai fazer aquilo, que é aquela preparação para o atendimento que faz tanta diferença, apesar de muitas vezes a gente ser surpreendido pelo paciente na sala de trauma, porque não temos um sistema de trauma no Brasil, né? Depois tem aí sobre comunicação em tempos de crise e até uma ferramenta proposta já clara no livro de debrief, que é como a gente conversa sobre o atendimento na sequência dele, né? O Stop the Bleed, que é um curso bem simples para pessoas que são os transeuntes, bystanders, os alunos na escola que tem... A gente já teve vítima essa semana de novo de criança morta numa escola no Brasil, isso não é exatamente como é fora daqui, mas está virando uma coisa um pouquinho mais frequente. E aí tem o curso do Stop the Bleed dentro do ATLS, que é uma dessas coisas. Sobre conteúdo, coisas que a gente já fala como especialista, tem alguns especialistas aqui, vários especialistas aqui que podem concordar, a gente já falava disso, mas isso não estava tão claro no curso. Então, por exemplo, sobre a ressuscitação, né, ou a reanimação volêmica antes da sequência de medicações para intubação, ou, por exemplo, o uso de push dose, que é até uma corruptela da medicina de emergência, associado à administração de volume para evitar o choque induzido pelas medicações, né? Que é uma coisa que a gente já conversava. Então, isso está mais claro no livro. Então, você tem uma tabela hoje que tem a primeira droga da lista, ketamina, que a gente já devia estar falando dela há bastante tempo, e hoje ela surge de forma diferente. Isso nasce de um conceito de que alguns estudantes focavam tanto na intubação que eles ignoravam o choque, e daí a gente agora coloca o X e essa abordagem antes da intubação para evitar que simplesmente a gente tenha falência e o paciente possa morrer simplesmente pela tomada de decisão da intubação e pela forma com que a gente faz, né? Agora a gente voltou a falar que toracocentese com agulha pode ficar em 2 lugares, o lugar que você souber fazer melhor, não tem quinto espaço, não tem segundo. Isso, na edição passada, foi parar em um outro espaço que não era o anterior. Na edição passada estava no quinto. Não são coisas que interessam aos presentes, né? A indicação de toracotomia aí para especialistas é um surgimento, então já não é mais volume-based, não é mais quanto sangrou no tórax para a gente indicar, é mais baseado na fisiologia do doente, né? E nem relacionado a quanto drena por hora. Então, são modificações da letra B. Letra C trouxe uma nova tabela, então as provas de residência vão mudar, porque agora não tem choque grau 1, 2, 3 ou 4. A gente tem agora uma que fala sobre grau de gravidade da hemorragia, e a gente não tem mais aquela classificação anterior. E aí essa tabela ficou bastante interessante. Alguns termos novos surgiram na letra D, no disability, então neuro worsening é um novo termo, né, que foi colocado, e esse uso de coisas, ou de tabelas, ou de classificações que são essenciais nas especialidades de onde ela vem. Por exemplo, a Asia Impairment Scale ou a Spinal Classification da AO, né? Então, a gente deixa de falar de uma tabela... Não, vamos usar a melhor forma de conversar sobre o assunto. E o livro, e o ATLS agora traz, e está ali embaixo à direita, os Goals of Care. Então, agora tem algumas coisas propostas, como objetivos do cuidado do paciente traumatizado. Por exemplo, ali na última frase, manter a pressão arterial média entre 85 e 90 por 7 dias. Então, agora tem afirmações postas, e isso ficou um pouquinho diferente, ficou mais dinâmico, eu acho que melhor, né? Você tem uma tabela, por exemplo, para uso de antibiótico em fratura exposta, então estou só mostrando aí, para dizer que os goals of care ficaram mais claros, né? A gente deixa de falar que é importante fazer antibiótico, e agora a gente tem uma proposta dentro do próprio livro, né? Assim como o trauma geriátrico, por exemplo, se baseia no conceito de fragilidade e não de idade, e apresenta isso de forma mais clara. Aborda, por exemplo, o uso de medicações anticoagulantes e como é que a gente reverte. Tem até tabela para como reverter o uso de anticoagulante. Essa, por exemplo, é uma tabela para avaliação de frailty, de fragilidade no paciente geriátrico ou no paciente mais velho. Então, a gente tem agora isso tudo proposto e não ficou como apêndice no livro, ficou como na sequência do atendimento. Então, facilita um pouco a compreensão, né? Aqui a gente está falando, por exemplo, de uma aula específica sobre como comunicar o desfecho negativo, a gravidade da doença ou a morte para o familiar ou para o acompanhante dessa pessoa que chegou no pronto-socorro. Então, agora a gente tem uma estação prática de comunicação de notícias graves e tem até modelo de como fazer. Então, o livro, porque é um livro de cabeceira, ele acabou ele não está tão pequeno como um manual e está tomando forma de uma coisa que a pessoa pode consultar outras coisas depois, né? E uma das coisas que foi trazida é um capítulo de Team Communication também, que é uma novidade dessa edição, que a gente agora não fica tão importante como já foi dito aqui há tão pouco. Comunicação entre os pares no atendimento do trauma faz muita diferença e existe uma proposta e existe isso tudo colocado para o aluno do ATLS, né? Então, eu estou falando em português de novo porque eu acho que isso faz muita diferença para quem é mais jovem, eles todos já sabem disso muito mais do que isso, né? A flexibilidade do curso, naturalmente, está colocada, relacionada, por exemplo, à pergunta número 1 ali. Quais são as opções se não tiver blood products? Então, se a gente não tiver componentes sanguíneos à nossa mão. Então, a gente pode ensinar de jeitos um pouquinho diferentes, baseado no local em que cada um de nós está. E aí o curso tem alguma flexibilidade para esse tipo de ensino, né? Então, se você atende criança, a estação de via aérea prática vai ter abordagem da via aérea de criança. Se você nunca atende criança, ela pode ficar de fora, porque não faz sentido ensinar, então tem alguma flexibilidade. Então, o curso mudou bastante, e está sendo lançado agora em agosto, né? Naturalmente, eu não ganho dinheiro com isso, eu não sou empregado, não sou assalariado do comitê, é só uma função. Mas o comitê de trauma tem outros cursos tantos, né? O Stop the Bleed, o ATLS, o Team, a gente tem um encontro agora em agosto e vai provocar a 4ª edição do Team, que é um curso para alunos de medicina, ou para alunos de enfermagem, é para não médicos, e ele é mais simples, um curso de um dia, assim como tem curso como o Atom, que é um curso de modelo animal para manobras em trauma, manobras cirúrgicas, ou o Asset, que é de exposição cirúrgica vascular no paciente traumatizado, que é feito em cadáver, esse do centro. Esse vai ter um curso em novembro, por exemplo, no Chile. Quem quiser entrar em contato pode fazer perguntas. Então, mais uma vez, esses são os meus contatos, eu represento o Comitê de Trauma Brasileiro, e gostaria de agradecer novamente a oportunidade de conversar, mas principalmente gostaria de parabenizar a excelente e notável conversa, porque esse assunto é mais importante, é besteira falar, devia estar no coração de cada um de nós, como o Covid teve na época da pandemia. Isso aqui vem matando todos os anos, todas as vezes, e a gente não vê tanta comoção. Talvez porque as histórias são pouco contadas ou porque a gente conta elas de um jeito errado. Então, obrigado e estou à disposição para qualquer conversa.
Obrigado, Dr. Rodrigo Vaz Ferreira. Let's invite the next international speaker, Professor Ari Lepaniemi from Finland. and he's the president of International Surgical Society. And he'll talk about the definitive surgical and anesthetic trauma care, the SATC course. And Professor Lepaniemi was in Brazil 2015 when was organized in Ribeirão Preto, the first SATC course in Brazil, with Professor Carlos Mesquita and Professor Sandro Rizzoli, a Brazilian who works nowadays in Doha, Qatar.
Madam President, Academian ELIETE BOUSKELA, distinguished professors, dear friends, colleagues, and guests, on behalf of the International Society of Surgery, Société Internationale de Chirurgie, ISS, SIC, and the International Association for Trauma Surgery and Intensive Care, IATSIC, I want to thank for the kind invitation to this wonderful place, which really breathes history of Brazilian surgery, and this very important meeting talking about trauma care and training in Brasilia. The STC, let's see, is the next step from ATLS. So it handles with something that happens in the operation room. So if ATLS is what takes place in the emergency room, this is what takes place in the operation room. For people who have experience in surgery and anesthesia, but not necessarily see trauma patients every day. It started about 30 years ago with some colleagues from Australia and other places having these kind of courses, and then it was sort of systematized and organized so that the first actual DSTC course was done in 1996. And with the recognition of the team, importance of teamwork, we later added anesthesiologists and also lately nurses, so that we really are a team-based training. We've done over 550 courses in 30 countries as the number is increasing. We just had one in Brasilia a week ago or so. The parent organization, IATSIC, is one of the integrated society of International Society of Surgery. And the principle for the course is very simple. Trauma surgery is not elective surgery. There are many differences, and that's why the course focuses on management decisions, probabilities, physiology and anatomy interaction, and techniques. So if elective surgery is about anatomy and physiology, trauma surgery is about physiology and anatomy. Sorry, anatomy and pathology, the elective surgery. So we talk about pattern recognition, probabilities, and protocols, because we don't have the luxury of all the information elective surgery usually has. We have to make decisions based on incomplete information. Goal being minimizing the time from injury to definitive care. Because time is life, time is limbs, time is bowel. Obvious first goal is to avoid preventable death, but also minimize the risk of adverse effects such as multiple organ failure or dysfunction, septic complication, long-term disability, and so forth. As in ATLS, we know the priorities, of course, that kills the patient first is the incomplete airway, then breathing, circulation, and so forth. We also are concerned about intracranial pressure, regional perfusion, for example, in the intestine, contamination, fractures, and so forth. So, because we have to make the decisions based on probabilities, it's one of the key components of the DATC course is how to make decisions and realizing that making decisions is often more important than making the diagnosis. Decisions we need to make are, for example, should we treat this patient or not? Is this patient dead or dying anyway? Should we go to the operation room or go to the CT scan? If we do X-rays, do we do CT scan? Should we do ultrasound first? Should we use MRI? When we operate, should we go for definitive repair of all injuries or resort to damage control surgery? Should we operate at all, or should the patient be treated non-operatively? Should we reconstruct everything now or leave it to the second stage? Just examples of decisions we need to do when we take care of trauma patients. So the approach to learning in this course consists of interactive presentations, practical or hands-on skills with animals. I'll come to that a little bit later. Case scenarios. The course has a number of cases we use for the particular courses, and they are real cases from all over the world, and we make new cases all the time, update the slides. Animals are part of the course, and we are very careful, and we think it's very important that the animal, we use mostly pigs. In Muslim countries, we have used goat, are well taken care of, that they don't suffer. We have a very strict protocol to, when the courses apply, that the animal ethics is completed properly. And we have people monitoring the anesthesia, veterinarians, veterinary anesthesiologists, or veterinarians to make sure that the animals are treated properly. We also are very strict with ethics rules, which means that the ethics lecture is mandatory to all participants as well as visitors, and only those can take part in the course. The other important component, and we heard Professor Alexandrino talk about teamwork in trauma, team performance, team effectiveness. Teamwork in DSTC is very important. We concentrate or try to concentrate on 5 things: on leadership, mutual performance, monitoring, backup behaviors, adaptability, and team orientation. We heard about non-technical skills, and they are very important, as we all know, when we treat the trauma patients. Nobody makes things alone. Nobody's an island. And when we talk about what we call high octane or high risk work, which trauma surgery is, you can't afford to have errors in non-technical skills or deficiencies in non-technical skills. And that's why we concentrate on teamwork, decision-making, situational awareness, leadership, task management. And in the center of all this is communication. Communication within the surgical team, communication between the surgeons, anesthesiologists, communication between the surgeons, the nurses, and anesthesiologists. Every member of the team has to be part of the communication circle. So what we try to achieve on those 3 days we have the course is that by the end of the course, the participants, we usually have the hands-on training. We have 1 instructor for every table and then 4 participants. This is standard. Sometimes we have 2 instructors, 1 more junior, 1 more senior. So what we try to teach is how to apply damage control principles in major trauma. Recognize when we need to do damage control surgery instead of trying to repair every injury at one go. How to prioritize investigations, the procedures, the patients who have multiple injuries, fractures, chest injuries, head injuries, abdominal injuries. and we try to demonstrate teamwork during the practical sessions. We sometimes take timeouts and make sure that the surgeon students are aware of what the anesthesiologists are doing and vice versa. So we take breaks and make sure that the communication is kept going all the time. We do a range of practical trauma management skills. We usually, depending on the level of the students, start with the easier ones. For example, we do laparotomy and do a splenectomy and maybe a nephrectomy or suture of the liver, packing of the liver. Then get to the more demanding ones. For example, in the chest, we do a release of or we do left anterior thoracotomy, release the cardiac tamponade, control bleeding of the lung with the hilum, cross-clamp the aorta, and then do repair of cardiac stab wounds. Those are the standards one. And then in the end, often we go back to the abdomen and do inferior vena cava repair or shunt major artery or the aorta with the temporary vascular shunt. So those are the skills among, and some others we try to do with the animal for the team. So it's a 3-day course. It varies a little bit. Usually day 1 is the lectures and cases. Day 2 can be the animals, and day 3, again, some cases. But that varies a little bit, depends on local circumstances, and there's no rigid format, but we need to make sure that we complete more or less all those tasks. It takes a lot of people. This is one of the courses we just had in Doha, Qatar. You can see that it takes a lot of people, a lot of work, and the organizers really need plenty of time and resources. It's not something you can put up overnight, and you need, frankly, you need money to do this also, so it has to be recognized. So trauma surgery is not elective surgery. Trauma is about physiology and anatomy. And this course works for teams, or aims at to get the teams to work as a unit, as a one cohesive unit to manage the individual trauma patients. We encourage the students to ask questions, interrupt, and often the faculty, we have usually several faculty from different parts of the world. Faculty sometimes often disagree, which is a good thing because there are no right answers in trauma surgery. The key is not what is the right answer. The key is how do you get there? The thought process is important. That's what we try to teach. Thought process, how you get there might be different from different people, and they both might be right. The question is how you get there and how you come to the logical conclusion when making decisions. Finally, just as my role as ISS president, I invite you all to the next World Congress of Surgery in Mexico City in April 2026. I hope to see you all there. Thank you very much.
Thank you, Professor Lipanemi. I would like to invite Professor Ilijana Lulic. She's an anesthetist in Zagreb, Croatia, and she'll talk about the European Trauma Course, the ETC.
Good afternoon, everyone. Dear friends, respected representatives of National Academy of Medicine, Madam President, Professor ELIETE BOUSKELA, thank you for your kind invitation. And foremost to Professor Fraga, Gustavo Fraga, and Professora Andrea Fraga, thank you for the extensive work you've done in the background to make it possible for us to be here for the past 2.5 weeks. So my name is Ileana. I'm a consultant anesthetist and intensivist working in Clinical Hospital Center Merkur in Zagreb, Croatia. And today I've been invited to talk about the European Trauma course. This is my disclosure. So I'm 44, still do not know how to cook. But in anesthesia, we usually say that challenges come in 3. So in trauma, as well as in real life, the uncertainty, the chaos, and the hunger often arrive all together. So when it comes for the next 10 minutes, I'm going to try to talk and to lead you through some of the ideas, the philosophy, and the vision behind the European Trauma Course program. We all know trauma is not inherently physically difficult, not necessarily physiologically difficult, but difficulty lies in the situationalness, meaning that trauma often comes out of the ordinary working hours and in highly stressed acuity situations where people might manage it that are experts, but not as an expert team. We realized that already in 2002, where there was a group of enthusiasts, trauma ambassadors, led by Italian guy from Rome, professor, and he was an anesthetist, Professor Giuseppe Nardi, personal intensivist of a Pope, who kind of brought the idea of assembling a team of trauma experts and experts in medical education. And that was actually the establishment of the European Trauma Working Group. This was their first meeting. During this meeting, it was in Bologna in 2002 in Italy, and they kind of made certain prerequisites that set the basis to start the program. Some of them that the course so itself should reflect the European practices, meaning that Europe no speciality is the owner of the trauma. Actually, all specialities, multidisciplinary, should kind of work towards setting the front line for the patient traumatized to be managed, meaning surgeons, anesthetists, radiologists, neuro surgery guys, as well as nurses. Apart from this, it was actually for the first time when the idea was brought to make this trauma team-focused life support course. And actually, we didn't know how to do it because there were not much experience. Some of my mentors say the story went in the other direction, that actually the whole idea was brought in a bar in Ireland where a bunch of guys had Guinness piles, but that's another story. So apart from the idea, we knew that we need a strong political background, so we're happy that we were embraced by the ERC, OISM, Estes, and ESAIC as our kind of partners in this new venture. And in 2006, actually, the European Trauma Working Group was approached by the Maltese Resuscitation Council, because at that time they wanted to improve trauma management, but they didn't have enough finances to kind of cover the costs of ongoing available trauma courses. So we accepted the offer. We said, okay, let's go there, although we knew that we are not ready. The material wasn't ready. We're far behind what was set up to be done, but we said, yeah, let's go. First, it's good for the program. And the second thing is that we're gonna, if something goes wrong in Malta, well, it's far away, you know, down there in the Mediterranean. We'll just pick up our bags, we'll go home, and nobody will know what happened there. But unfortunately, or fortunately, it went pretty well. This is the first group of the first pilot course in Malta, run in 2006. These are all trauma experts from UK, Germany, Malta, Italy, and it set the story off. So after this Maltese first pilot, we had 3 more pilots, and then in 2008, during the European course, European Resuscitation Congress in Ghent, Belgium, the first course, European trauma course, was ever held. That was in 2008 in May. So what is the European trauma course all about? What is the philosophy? It's a 2.5-day course with heavy immersive hands-on simulation training. We focus strongly on non-technical skills, and it is all about the teamwork. So we cover all aspects of trauma, airway, thoracic, abdominal. We put an emphasis on special circumstances as well as special populations as kids, elderly. It is 85% hands-on training, so simulation-based. And our target groups are physicians, as I said, critical care specialists, together with nurses and other supporting practitioners. Today, we have spread out from the borders of Europe. We are running in more than 25 countries. Although we are called European, we are running the course in North Africa, Middle East, and now Americas. And we train more than 20,000 healthcare professionals. And then the beauty comes in 2019 when a group of enthusiasts from Lusitanian ALTEC, Lusitanian Society for Trauma and Emergency Surgery, under the guidance of Dr. Carlos Mesquita, who is sitting there, one of my mentors and great friends, pick up the bunch of trauma enthusiasts from Brazil, train them in Coimbra, Portugal, and after a set of consecutive courses, brought the whole story into the Americas. The first course was held in Campinas, Brazil in May 2019. This is us. I had the privilege to be there. The greatness in what happened in Brazil, although it's quite we are newlyweds. Yeah, it's now we've run the 12th course, and the beauty is that it's possibility to kind of tailor the course to local practices and local policies and local needs. So what is the evidence? How good are we? Where are we? What's up there? Well, there are no RCTs. These are some of our recent publications. Most of them are narrative reviews and some kind of survey, cross-sectional surveys. But I'm happily to kind of give you a sneak peek in some of the future results of Professor Casellis. This is his team work. So actually, he was one of he is actually one of our big ambassadors. This is his team in Hospital Federal do Baso, right? And they are preparing to receive a trauma patient. This is like in real situation, this is the team leader and this is how they work. So dynamically, as trauma kind of dynamically changes from second to second, from minute to minute. All these guys, A, B, C, D persons are working together as a team led by this team leader. So what he said is that some of the data says that there might be a 60% of the reduction of mortality, not solely by implementing ETC principles, also political policy changes, other training modalities, but we are happy and proud to be a part of it. So in conclusion, this is me on my second year of residency in 2012. In the trauma bay after we ran our first trauma resuscitation according to European Trauma Course principles. I just want to leave you with smile on our faces and keeping it simple and standardizing the protocols. I believe we can all keep these smiles in future on our faces. Thank you very much.
Thank you, Professor Eliana. So I'd like to invite Professor Fausto Catena from the University of Bologna, Italy, and he'll talk about emergency abdominal surgery course, Bologna. Yes, and Professor Catena is director of the World Society of Emergency Surgery.
Thank you to the President of Accademia Nazionale di Medicina. Thank you to the organizer, Professor Fraga, Professor Camargo, Professor Fiorelli. Thank you to the moderators. It's a great honor to be here in this fantastic historical place. Up to now, as you know, there were presented a lot of trauma courses. But there is another time-dependent disease that is emergency surgery, appendicitis, cholecystitis. And it is a sort of orphan disease. Nobody wants to do it because it's better elective surgery, because it is more rewarding, elective surgery, you can do money and so on. This guy is Michael Sugrue, that is the father of this course that is tailored on emergency general surgery. And they developed it about 13 years ago. This course is about the possibility to share knowledge between the faculty, with residents, with consultants, with students, with nurses, to understand which is the decision making. I have a patient with an acute abdomen. What I have to do? We have to answer to this simple question. And this is performed with case presentation, with a lot of interaction between faculty and attendees. We discuss surgical approaches. There is a literature update with guidelines, but above all, people are invited to think about their job and to think about patients. This because the course is about attendees that have to learn, but also, and above all, it is about real patients that have to heal of their disease. In the courses, there are very different clips about real patients that explain their disease. And this is the starting point to discuss and to analyze the decision making as a pathway that we evaluate for the diagnostic workup and for the treatment. These patients can have an height mortality. It is calculated that if they are elderly and they have a peritonitis, this mortality can be more than 20%. So the course here is about doctors, it's about the needs, the educational needs of the doctor, but it is also and above all about patients and all the staff that is treating the patient. As I told you, it was created by Professor Sugrue that works in Letterkenny University in Ireland, nearby Dublin. There is no payment for the faculties, totally volunteer on a volunteer basis. There are not royalties. It is a totally volunteer course that is a property of the Donegal Clinical Research Academy. But now it is also a donation to the World Society of Emergency Surgery. It started in 2012. But after that, we did various editions. This is one of the my favorite one. It was in Dublin in 2016, and it was combined to a Congress of the World Society of Emergency Surgery. These are the places where the course was performed in the last years. You can see we were able to cover all continents. Again, even in this case, Africa is an exception. We have to do something about it, and we will do something about it. It involved more than 3,000 participants. There are different types of course. One is for consultant, another one is for medical students. The third one is for nurse. There is a further one, it is an intermediate for consultant and for trainees, for residents. And there is a train the trainer course that is a course where you try to train the future instructor for the emergency abdominal surgery course. There is a website where you can find the contents of the course, but also you can register. This is the address of the website. And the student EASC was also run with a virtual platform, but also the consultant course was performed this way during the COVID period. And the students' course was defined as the best educational experience in 6 universities in the world. This is an example of the program. The program is composed by many lectures on the most important topics of emergency abdominal surgery. They are tailored again at the level, so they are different if they are for consultants or if they are for students. And this is an example of a lecture. So in the lecture, there are the goals of care. Then there is an exhaustive discussion of literature. And then it is summarized which are the best diagnostic workup and which are the best treatment pathways. The surgical technique is for every disease well defined. This is very important because it is a course for consultant surgeons. When we run the course for nurse and for residents, it is a little different. After each disease presentation, there is a case presentation. This is a case presentation performed by Carlos Mesquita yesterday. So there is a presenter of the case, of the clinical case, with an AV approach, audiovisual approach. And there are 4 or 5 experts in the faculty. And the experts are all one against the other. This is important because we have to demonstrate that there is not one single best decision. There are many different decisions that are different according the patients, according the country, according the personal and evidence-based approach that the surgeon has. There is an assessment before the course with a multiple choice database, and there is also an assessment after the course. Because after the course, it is very important that the attendees could achieve the best of the surgical latest evidence. And so he could have an open mind to deepen the contents and to have a real knowledge of what he has to do with these time-dependent diseases. The test after the course is performed with the survey monkey, and then the attendees will receive the feedback. So, this course is very important. It's very important because it is one of the few courses that we have in the world about emergency general surgery. Emergency general surgery is important as it is important trauma. They are both time-dependent disease, and they are both diseases that needs a quick decision making and a great capability to understand which is the best way to do with it. But again, it is important to understand which is the role of the rescue surgery, so how to deal with the possible complications that a surgeon can have, and how to save the patient with different damage control procedures. The last slide is to invite you to the next Congress of the World Society of Emergency Surgery that will be in Antalya, in Turkey, in October 2025. Thank you very much for your attention.
Thank you, Professor Fausto Catena. And I'd like to invite Professor Carlos Mesquita. He's from Coimbra, Portugal. He's known as the Godfather, and he'll talk about the tetrahedron of emergency surgery.
Boa tarde. Eu começaria na pessoa da professora ELIETE BOUSKELA, académica presidente, por cumprimentar a Academia Brasileira de Medicina e agradecer esta oportunidade que muito me honra. My excuses to our fellow foreign colleagues, but I'm going to speak in Portuguese because I think it will be much better to me, and I think also for the students and the audience. Então, nestes breves momentos, aquilo a que eu me irei referir será um pouco a síntese daquilo que já foi dito por todos os colegas e um pouco aquilo que tem a ver com o trabalho que com o Gustavo Fraga, com outros colegas, o Sandro Scarpellini em Ribeirão Preto, a Amauri em Maceió e muitos outros no Brasil, o trabalho que nós temos vindo a desenvolver nos últimos 15 anos. Tem sido uma colaboração profícua entre os nossos dois países e mais particularmente entre a Associação Lusitana de Trauma e Emergência Cirúrgica, que neste momento é presidida pelo Henrique Alexandrino, que falou há bocado, e a Sociedade Brasileira de Trauma, de Atendimento ao Traumatizado, a ISBAIT. Este é o hospital onde eu trabalhei quase toda a minha vida como cirurgião, neste momento, desde há 3 anos que estou retirado, é o Hospital da Universidade de Coimbra, e é um hospital central, portanto, não só para a região centro do país, como para o país inteiro, porque é a maior instituição hospitalar do país, é aquela que conta com todas as valências e que acaba por receber doentes é o único hospital central para a região centro, mas acaba por receber doentes também um pouco de todo o país, em função de algumas valências que nós temos, outros não têm, nomeadamente, por exemplo, angiografia 24/24 horas. Temos um serviço de urgência dinâmico, grande, com um grande número de doentes. Neste momento, o Henrique Alexandrino é o diretor desse serviço, mas quando nós olhamos para os nossos números, e isto aqui a realidade é muito diferente da do Brasil, e olhando, isto eram os meus números pessoais, mas podem ser os de qualquer cirurgião em final de carreira. E o que é que nós vemos? Vemos que no âmbito da cirurgia de emergência e de trauma, aquilo que tem a ver com o trauma e com a cirurgia do trauma em particular, não são números muito elevados. Ainda bem, significa que não é um problema que nos ocupe com tanta frequência. Mas a verdade é que, se por um lado é bom termos uma mortalidade e um número de casos baixos no que diz respeito à cirurgia do trauma, portanto cerca de 27%, a verdade também é que isto nos diz que nós temos que estar preparados para lidar com estas situações e, portanto, desde há 25 anos, mais ou menos 1998, 99, que começámos a trabalhar no sentido de apostar seriamente na preparação dos nossos colegas, dos especialistas, dos residentes, dos estudantes, e há aqui dentro, este é o portfólio da nossa sociedade, da nossa associação. Mais ou menos estão aqui focados todos os cursos que hoje foram aqui falados, desde o ATLS, do American College of Surgeons, ao European Trauma Course, ao qual a ESTES está ligada, ou ao DSTC, ou aos cursos correspondentes para anestesistas e enfermeiros de bloco operatório no âmbito da IATSIC. Mas eu ia concentrar-me um pouco mais na parte do trauma. Também estão aqui em baixo referidos o Emergency Abdominal Surgery Course, que o Fausto Catena acabou também de mostrar, e um outro que é o Emergency Surgery Course da ESTES. Eu ia focar-me agora um pouco mais, então, naquilo que são os cursos dedicados ao trauma e não tanto àqueles que são dedicados à cirurgia de emergência não traumática. E nesta medida, um dos passos importantes, estão aqui as datas, nós começámos a trabalhar nisto de uma forma, ao princípio, relativamente despegada, mas depois um passo importante correspondeu a esta fase, que é o acordo de geminação entre as nossas duas sociedades, entre a Altec e a ISBAIT, através do qual todos os nossos sócios são sócios da ISBAT e todos os sócios da ISBAIT são sócios da Altec. A única diferença é que nós não podemos votar no Brasil e eles também não podem votar em Portugal. Mas em todo o resto, de facto, trabalhamos em termos de igualdade. Então, o que é que, no fundo, de onde veio o nome desta comunicação? A determinada altura, nós precisávamos de perceber o que é que estávamos a fazer e o que é que poderíamos fazer mais para que pudéssemos avançar de uma forma consistente. E procurámos, e o modelo que nós encontramos para o nosso trabalho é um modelo simples, baseado na pirâmide triangular, no tetraedro, que é a forma, como todos sabemos, para além dos aspectos místicos que estão aqui contemplados neste slide, é a forma geométrica mais simples de todas e aquela que, desde sempre, e aproveitando aqui já do tempo do Pascal, aquela que encerra dentro de si uma esfera que para nós, neste caso concreto, representa a esfera de conhecimento na área do trauma e da cirurgia de emergência, em particular do trauma. E esta esfera, ou a dimensão desta esfera, resulta um bocado da pressão que os diversos vetores, ou os vértices neste caso, fazem sobre ela. E, portanto, quanto maior ela for, quanto mais peso os vértices tiverem, seguramente maior e talvez mais robusta será a nossa esfera de conhecimento. Neste caso, no trauma, de que é que estamos a falar? Estamos a falar, em primeiro lugar, do ATLS, que já foi hoje aqui referido, e que para nós simboliza muito, embora hoje em dia esteja mais focado também a dar mais atenção ao trabalho em equipa. A verdade é que desde o princípio foi sempre importante na avaliação longitudinal do doente, sequencial. Normalmente tem a ver com o médico que trabalha sozinho ou relativamente isolado e que tem que saber abordar um traumatizado de uma forma correta, daí vem o A, B, C, D. Mas isto é um princípio. Depois, há de facto as vantagens e a necessidade, que essas são dadas pelo European Trauma Course, que já tem muito mais a ver com o trabalho em equipa. Já não é um médico isolado a fazer uma abordagem longitudinal, já é um médico numa urgência hospitalar, numa equipa organizada, em que já existe o doutor A, o doutor B, o doutor C e o doutor D, e em simultâneo eles caem sobre o doente e cada um está a desempenhar o seu papel. Daí a importância dos chamados non-technical skills, a importância da comunicação entre todos eles, e tem que haver quem coordene. Mas estes dois cursos, que são cursos essencialmente intensivos, no fundo, não chegam, não é? Algo mais tem que haver. No caso da cirurgia, por exemplo, teve o Ari Lepaniemi a falar, é o DSTC, que já traduz, dentro do trauma, uma abordagem especializada. Tanto pode ser a do cirurgião, como pode ser a do anestesista, no DATC, como pode até ser a do enfermeiro, do bloco operatório, no DPNTC. E então, onde está o quarto vértice? Onde está o quarto elemento deste jogo que nos permite criar a esfera de conhecimento? Está, seguramente, naquilo que o Gustavo Fraga tem andado à procura e a tentar fazer para o Brasil e que nós também temos tentado a fazer para Portugal, que é na criação de uma forma estruturada de treino em formação contínua. Isso chama-se uma residência, ou uma subespecialidade, ou uma especialidade, conforme a realidade local, e de facto é isto que nós estamos agora também a tentar fazer em Portugal. Avançámos bastante no seio da Ordem dos Médicos, o Henrique Alexandrino é o coordenador desse grupo, está neste momento criada uma comissão instaladora e oficialmente criada uma subespecialidade de cirurgia de emergência que inclui o trauma. E, portanto, aquilo que eu gostaria de dizer é que espero sinceramente que o mesmo aconteça aqui e desejo ao Fraga e aos colegas do Brasil o maior sucesso dentro desta pretensão, porque, de facto, é a melhor maneira que nós temos de tratar os nossos doentes. E é fundamental, de facto, que saibamos todos caminhar no mesmo sentido, juntos e em espírito de colaboração. Muito obrigado.
Agora nós vamos ouvir os comentários do acadêmico Alberto Schneider, por favor.
Good evening, dear President, Professor ELIETE BOUSKELA, dear academicians here present, composing this table. I would like to thank the organizer of this symposium. I'm very honored to be here with such important colleagues. I will speak in English, but also in Portuguese. I would like to engage this symposium involving the medical student formative learning in trauma and also emergency surgery. Então, eu gostaria de trazer para a discussão a formação dos estudantes de medicina, and even residents, e também dos residentes, com relação ao trauma e às emergências cirúrgicas. I'm very concerned about the design of the curriculum. For instance, how to prepare our students and even residents, also I said, to deal with the trauma in climate emergencies and others environment calamities. More and more frequent. Então, uma das perguntas que eu quero fazer, ela tem a ver com a abordagem da estrutura curricular e como nós preparamos os nossos estudantes frente a essas calamidades públicas e emergências ambientais cada vez mais crescentes que nós temos observado. I would also like to ask a question to Professor Carlos Mesquita about the standard, the uniformization for teaching learning process. I know that you have a beautiful hospital, emergency hospital in Portugal, but I would like to take into account the situation that in Brazil, for instance, we have a lot of university hospitals that don't have an emergency department room open. This has an explanation. Generally, when we have an open emergency room, there is a high probability to prolong the stay of the patients, which in turn occupy beds for patients undergoing elective surgeries. How do you deal with this situation? Eu estou perguntando, em suma, como é que é realizado, e aí eu estou especificando para o professor Carlos Mesquita, o atendimento de emergência voltado às instituições universitárias, porque na nossa realidade, no Brasil, em muitas ocasiões, nós não temos condição de manter uma emergência aberta, porque o aporte é muito grande, e os leitos acabam sendo ocupados por uma longa permanência, impedindo que pacientes eletivos, de cirurgias eletivas, possam ser contemplados. Então, como lidar com essa situação e como a sua instituição faz isso? E uma última pergunta, que eu acho interessante, e aí pode ser para qualquer um dos palestrantes, como é que é visto hoje o trauma e a emergência cirúrgica? Seria uma subespecialidade, considerando que nós temos outras emergências de igual relevância, pediátrica, obstétrica, psiquiátrica. Então, como que nós podemos considerar hoje o trauma e a emergência dentro das especialidades? Eu vou dar só um exemplo. Há alguns anos atrás, o Ministério da Saúde divulgou um manual para um serviço que aqui a gente chama de SAMU, que é um atendimento de emergência em via pública por ambulância, e apenas esse manual de atendimento pré-hospitalar, ele tem mais de 650 páginas. With the exponential evolution of the knowledge, I would like to know if the lecturers could give their opinion about the subspecialty in the emergency surgery. And if they consider that today, nowadays, emergencies such as pediatric, psychiatry, and obstetric are subspecialties. And as a matter of curiosity, a couple of years ago in Brazil, the Brazilian Ministry of Health published a guideline for SAMU. SAMU is a mobile emergency care service done with ambulance in Brazil. But for the first pre-hospital approach. But this guidelines has almost 650 pages. How to deal with the growing knowledge nowadays. That is my consideration. São essas minhas considerações. Thank you, Mr. President, and I would like to thanks again for this opportunity.
Muito obrigado pelas questões que me está a pôr. Eu, se me permite, e a senhora Presidente, iria responder à segunda parte e deixaria a primeira para o Henrique Alexandrino, porque, de facto, ele é neste momento o diretor, é ele que tem que lidar com esse problema de como responder e o que fazer aos doentes que tendem a ficar internados no serviço de urgência. Pode ser? Então, indo à segunda parte da pergunta, a questão da especialidade ou da subespecialidade, isso depende muito da organização médica de cada país. Em Portugal, tudo isto é decidido dentro da Ordem dos Médicos e há um regulamento de colégios e dentro dos colégios está previsto existirem colégios de especialidade, secções de subespecialidade dentro de um colégio de especialidade e colégios de competência. O conceito de competência é mais ou menos aquilo que no Brasil se chama uma área de atuação. Portanto, é uma questão transversal, o acesso à competência pode ser feito por médicos de especialidades diferentes, desde que tenham um interesse comum. Por exemplo, uma das competências que temos criadas há muitos anos é a competência em emergência médica. Só agora, recentemente, é que foi criada também uma especialidade, vai haver um colégio de especialidade de medicina de emergência, medicina de urgência, aliás. Mas até agora havia, de facto, essa competência transversal que corresponde um pouco àquilo que aqui é, julgo eu, que se chama uma área de atuação. Quanto às subespecialidades, elas estão previstas, mas, curiosamente, o seu desenvolvimento tem sido muito pequeno ao longo dos anos. No caso, mas, por exemplo, dentro da pediatria, há várias subespecialidades. Dentro da psiquiatria também há. Na cardiologia também há, mas no total de 50 ou 60 colégios que nós temos, é um número relativamente reduzido. Curiosamente, no caso da cirurgia, em que elas existem na prática, porque quase todos os serviços hoje em dia estão organizados em termos de um setor de coloproctologia, de cirurgia patobiliar, de cirurgia geral e endócrina, está-me agora a falhar um deles, não faz mal. Mas nunca até agora, a esófago-gástrica, nunca até agora, nos diversos hospitais, mas sobretudo nos hospitais maiores, nos hospitais centrais e universitários, ainda não foi possível, em nenhum deles, e a nível da Ordem dos Médicos, levar à criação formal destas subespecialidades. Curiosamente, e aquilo que não era de esperar, a primeira subespecialidade a ser criada dentro do colégio de cirurgia foi a cirurgia de emergência, onde à partida devia ter sido a última, era natural que os outros já se tivessem adiantado. Portanto, para a nossa realidade, enquanto que no caso da medicina se entendeu bem criar uma especialidade de raiz, com um internato, uma residência, como aqui se chama, de raiz para a medicina de urgência, o que foi um processo muito complicado, no caso da cirurgia, nós entendemos que a melhor solução, até era porque todos têm que ser cirurgiões, a cirurgia em Portugal tem um internato de uma formação de 7 anos, a cirurgia geral, que é 1 ano comum mais 6 de formação específica, e entendeu-se que só depois dessa formação estar completada é que se devia dar acesso, portanto, ao cirurgião a ter a subespecialidade. Portanto, entre nós não se colocou, porque a realidade é diferente. Aqui no Brasil, como o Gustavo dizia, portanto, com um processo mais curto de formação geral, entende-se provavelmente que a solução seja um pouco diferente. Agora eu penso, há muitas formas, há formas diferentes de cozinhar bacalhau, tantas quantos dias do ano, eu penso que nós aqui também podemos ter formas diferentes de atingir os mesmos objetivos e, mais uma vez, eu espero do fundo do coração que ele consiga atingir os dele e que os brasileiros consigam atingir este objetivo, que será muito importante. Eu passaria agora ao Henrique.
Muito obrigado pela questão. Havia 2 questões, uma relacionada com os prontos-socorros, os serviços de urgência e emergência abertos e o impacto que tem nas instituições, e havia depois também uma questão inicial sobre o treino dos alunos de medicina em catástrofes ambientais. Não sei se também pretende a resposta a essa, mas em relação à questão concreta que me foi endereçada pelo Dr. Carlos Mesquita, de facto, os serviços de urgência vivem neste momento uma realidade que estão no limite das capacidades ou muito próximo disso. E isso cria desafios importantes para todas as instituições. Costumamos dizer que o serviço de urgência não está a serviços de urgência cheios, há hospitais lotados. E o serviço de urgência, por inerência daquilo que, da sua missão, e os serviços de urgência abertos, digamos assim, são o único serviço hospitalar que não pode estabelecer o limite da sua capacidade de resposta. Todos os outros serviços podem estabelecer o seu limite de capacidade. Um serviço de cirurgia podem estabelecer um limite de leitos de internamento, de doentes que opera, um serviço de endocrinologia. Portanto, todos os serviços podem atingir um limite de capacidade, de dizer a partir do qual, a partir deste momento, atingimos o nosso limite. O serviço de urgência, por inerência, não tem. E, portanto, tem que se assentar em duas respostas. Uma é a resiliência, ou seja, a capacidade de recuperar de eventos de crise, e outra é a flexibilidade. O serviço de urgência deve ser visto como um serviço que tem que cultivar isto. E este cultivo, regressamos à questão, treina-se, desenvolve-se treinando as equipas, treinando os indivíduos e sobretudo as equipas na capacidade de resposta perante a adversidade, perante os vários desafios que são colocados. Mas também é preciso ver que estes serviços de urgência abertos, estes pronto-socorros, são uma oportunidade única de ensino, porque o ensino, não só pré-graduado como pós-graduado, encontra no serviço de urgência um dos melhores laboratórios de ensino capaz, obviamente uma política estruturada, com responsabilidade, com previamente ensino baseado em simulação, e portanto nestes desafios também encontramos muitas oportunidades.
Gustavo. Excellent question, Professor Schneider. Today, in this beautiful auditorium, we have 12 international speakers from 10 different countries. If you look about the curriculum of undergraduates, maybe you have 10 different curriculums. Each country is different. I think the main problem in Brazil nowadays are the higher number of medical schools. Last March, there was a discussion here about how to prohibit to have more schools in Brazil. And I think more 95 schools are coming the next months. So you need to have a strong collaboration between the societies, Conselho Federal de Medicina, Associação Médica Brasileira, e all specialty societies to take control of this. The Brazil has a high number of specialties, 54 specialties in Brazil, and another 50 areas of subspecialties, área de atuação. It's a high number. The problem is that trauma was a specialty until 2003, when you start to have the symposiums organized by Conselho Federal de Medicina, Academia Nacional de Medicina e Comissão Nacional de Residência Médica, 23 years ago, there was a decision to have a regulation about the specialties. But at that time, trauma was a specialty that was created at University of São Paulo, Professor Dario Birolini. After, University of Campinas, Professor Mário Mantovani. Hospital de Pronto-Socorro, Porto Alegre, Professor Hamilton Petri de Souza. And Hospital Cristo Redentor, Porto Alegre, Professor Charlie Camargo. Only 4 programs in the 90s, the beginning of the 2000, only 4 programs in Brazil. There was a question that came from the AMP and Conselho Federal de Medicina to the Brazilian College of Surgeons in 2003, if trauma should be a specialty. The answer was, no, it's not necessary, because if you train the general surgeon, they can take care of the trauma patients. It's impossible. Brazil is a continental country. Only general surgeons will not take care of the trauma patients. And the problem with the general surgery in Brazil, that used to be only 2 years, and now you have the problem with 3 years, 90% at least of the general surgeons go to the other specialties. thoracic surgery, vascular surgery, urology, plastic surgery. Less than 10% of the physicians who have the choice to become a general surgeon works as general surgeon. In the big cities, you don't have general surgeon anymore. Brazil needs general surgeon. Maybe not in the city of Rio de Janeiro, São Paulo, Campinas, Brasília. Maybe in small cities. Because the general surgeon, he trained only 3 years. Why in Brazil, in 3 years, you have a good general surgeon? The United States, Europe, they need at least 5 years. With this new generation, quality of life, 6 hours per week. In Scotland, only 48 hours per week they work. But in Brazil, 6 hours. All surgeons in this audience, trained as resident, at least 90 hours per week. And I think sometimes was not enough because you need to practice. So the proposal of this symposium is in the title, is the multidisciplinar approach. We need emergency medicine physician taking care of the patients in the first care of the patient at the emergency department. You need orthopedics because of the motorcycle, a lot of fractures, open fractures, you need orthopedics. The last 2 days we were at Brazilian Society of Anesthesiology in Barra da Tijuca. They have a very beautiful simulation center. There were 2 days discussing with 5 national societies about protocols to traumatic brain injury, just to have a protocol, a guideline to use in Brazil. Since the pre-hospital, there was a table discussing pre-hospital, emergency department, neurosurgery, and ICU, with Associação Médica Intensiva Brasileira, AMIB. The problem is it's very difficult to attract the new generation to work with emergency. This is what you need to think. Who will take care of us in 10 years at the emergency department? Emergency medicine, they had a huge program. And if you go to Demografia Médica 2025, Demografia Médica is a program that a report of the medical situation, education in Brazil. Emergency medicine was the program who increases a lot the number of residents because it's a new program, only 10 years, was created in 2015, was the last one. But we know, I am professor of trauma, full professor of trauma surgery at my university, University of Campinas. My career was after 2 years general surgery, 2 years trauma surgery, master, PhD, 1 year in San Diego, University of California, San Diego, learning about how to organize a trauma system. I come back to Brazil, it's impossible to organize. We had the opportunity in Brazil with the World Soccer Cup, with the Olympic Games in Rio de Janeiro, to organize the trauma system in the city of Rio de Janeiro. Professor Rossano, remember, many surgeons from Rio went to Miami to train. Hospital Estadual Alberto Torres, Hospital Alberto Pereira Nunes. They have a well-organized system, but so many difficulties. And they don't have surgeons prepared. The surgeons that went to 9 years ago during the Olympic Games to Miami, few of them are working as a trauma surgeons because there are no opportunities for them. So you need to change. You need to have the collaboration. You need to have the support of Academia Nacional de Medicina, the Brazilian College of Surgeons. I'm looking for Dr. Pedro Portari, is our president, but he haven't arrived yet. After, maybe you can call during the break. You need to have trauma and acute care surgery as a specialty in Brazil. In Portugal, maybe it's not necessary. Italy, either. Scotland, either. But if you don't do this in Brazil, then 10 years ago, there were 22 programs in trauma, only 1 year in Brazil. Nowadays, maybe you have 6 or 7. Demografia médica, 2025 again. Only 9 residents on trauma program last year. Only 9 to a continental country. Why not? They don't want to apply for trauma. There's no opportunity. If you go to a private hospital here in Rio de Janeiro, Rede D'Or, you don't need to have a specialization in trauma to work in a very nice hospital. They will not ask you to have this kind of, in Brazil is a specialty, it's RQE, is a title that you have after the residence. So I think it's time to change because you were wrong the last 20 years. It's very easy to have a new specialty. We have the support of the Deputy Câmara in Brasília. There was a meeting, audiência pública, last May 6th. There's a deputy, Dr. Ismael Alexandrino. He is a physician, intensive care. He has special intensive care, and he supported this idea to have trauma surgery as a specialty. We hope during the Congress of the Brazilian College of Surgeons next month here, August, in Rio de Janeiro, have a big debate about this topic and try to change this. Without this, we will have a lot of preventable deaths in the next years. And maybe one day can be one of us or our relatives or friends because their hospitals are not prepared to treat critical trauma patients. Thank you.
I would like to ask you, and it is in the context, I think it's suitable in this context. What do you think is the future role of AI and robotics in trauma and emergency surgery?
Yes, there is a good future for AI because we use AI every day. And for robotic emergency in stable patient, yes. But for a critical patient, you need to learn with Dr. Mesquita a laparotomy because if the patient in shock, you die, you never do a robotic. So there are so many protocols, guidelines, how to treat the patients. For a stable patient, maybe in the future, the new generation, they use laparoscopy, robotic, but the patient who was very critical in the pre-hospital, arrived in the emergency department, shock, he needs an ultrasound, massive transfusion protocol, you need the hematologist, you need to bring the anesthetist to our emergency department. If you go to Portugal, the anesthetist go to the emergency department. In Brazil, they don't go. They stay, wait for the patients in the war. So it's a multidisciplinary approach. You need so many specialties to treat a critical case on trauma. Sometimes I need support of Dr. Rossano, has experience in thoracic surgeon, cardiovascular surgeon, you have an aortic injury. The trauma surgeon not do the treatment, but you need to call the endovascular team to put a stent. So you need to work together. This was the course, no technical skills for surgeons and the anesthetists that was organized at Institute of the Sociedade Brasileira de Anestesia 2 days ago from the University of Edinburgh. Was very nice. Very, very nice. Arthur?
Haveria tempo para mais uma observação? With all respect to my foreign colleagues, I'm going to speak this part in Portuguese. Eu pareço que eu estou voltando no passado, quando eu era cirurgião de trauma, em 1997, e nós estamos tendo as mesmas discussões. Eu vou dar minha experiência, que vai responder a sua pergunta. Precisa treinamento para cirurgião de trauma na Escócia? Não. Eu estou lá fazem 8 anos. Eu operei 6 laparotomias em 6 anos. Eu fiz nenhuma toracotomia. Em Curitiba, eu fazia, numa noite, 4 laparotomias e, às vezes, 1 ou 2 toracotomias. Trauma é uma especialidade do Brasil. Nós deveríamos estar liderando. Não precisava ter nenhum estrangeiro vindo aqui explicar. Nós deveríamos estar indo para fora e ensinar, porque nós temos os pacientes, nós deveríamos estar avançadíssimos nesse setor. Nós tivemos, durante esse curso aqui, residentes meus que vieram lá do Reino Unido, eles queriam ver trauma, porque eles não tinham, não tem trauma lá. Eles querem vir. O Reino Unido, quando precisa, o exército do Reino Unido e o exército, a marinha, quando precisa treinar, eles mandam pessoas para a África do Sul e para a Jamaica, que falam inglês, para poder ter o treinamento, porque senão eles nunca vão ver trauma. E eles precisam ter um volume de trauma, porque, como eu disse na minha apresentação, o currículo é por competência, eles têm que ter a competência. Então, eu acho que a especialidade tem que existir, e já passou do tempo de existir. Tem que existir a especialidade do trauma no Brasil, e tem que ser muito bem paga, tem que ter fundos. Eu trabalho num hospital onde eu tenho 12 PAs, que significa Programmed Activities. 2 dessas atividades são para estudo. Eu tenho um tempo dedicado do meu trabalho, pago, para estudar, para fazer avaliação dos residentes, para poder explicar para o residente, dar feedback para o residente, para conversar com o residente, para estimular eles a publicar, fazer auditoria. Os meus colegas que são professores, eles têm 4 atividades clínicas e as outras 8 atividades clínicas que são pagas são acadêmicas. Então, você veja, é uma questão de olhar para isso com seriedade e tornar uma especialidade, ter os fundos, esse que é o futuro para o Brasil, e sermos líderes. Eu acho que isso é uma mensagem que eu gostaria de trazer. Nós temos que liderar isso. Nós temos os pacientes, temos cirurgiões fantásticos no Brasil, com extrema capacidade. Se eu perguntar aqui para o meu residente que está aqui comigo aqui hoje, o que ele fala de mim, ele vai dar um feedback bom para vocês. E sou formado aqui em Curitiba. Muito obrigado.
Com estas intervenções, nós declaramos terminada a primeira parte, mas antes de irmos para o chá acadêmico, eu não poderia deixar de cumprimentar o brilhante trabalho do acadêmico Nicanor Macedo e dar os parabéns pelo aniversário de um dos nossos decanos, acadêmico Basílio. Parabéns para os dois. Então, vamos agora ao chá acadêmico.